Members, welcome to our meeting this evening here in the St George's Centre. Can I first call for apologies for absence, please?
Councillor Cook.
Thank you, Councillor Mine.
Chair, I'm substituting for somebody, I don't know.
Councillor Jackson, Councillor Jones, thank you very much. Thank you for that. Councillor Brake.
Thank you, Councillor MacDonald. Apologies from Councillor Wildey tonight. And I'll leave it to Councillor Barrett to do his apologies for somebody else.
Thank you, Councillor Brake. Councillor Barrett.
Yes, I'm substituting for Crashy and Ag this evening. Thank you.
Thank you, Councillor Barrett.
We also have apologies from Councillor Croser as well.
Sorry, I should have mentioned Councillor Clark will be here by about 7 o'clock. He has difficulties with trains from London.
Thanks, Councillor Brake. Can I call for agreement for the record of the meeting held on the 17th of October, which I know that Councillor Prenter chaired very well. Can I call for that being agreed as a correct record? Agreed? Thank you. Urgent matters. I have no urgent business to announce. Can I ask if there are any disclosable pecuniary interests or other significant interests or any declarations of whipping? Please report the interests if needed. Councillor Hamadeshi.
Yes, I work part-time for KMPT, and it's my understanding they're not attending today, so I will not have to leave the room.
Thank you, Councillor Hamadeshi. Okay, so before I move on, can I ask all those introducing reports, please assume that all members have read their documents, and I do know that all our members have read the documents, so please, can you keep your introductory parts very short if possible, please. Okay, we go to item 5, Kent and Medway Integrated Care Strategy. David Whiting to introduce.
Thank you. Medway is one of 3 statutory partners in the Kent and Medway Integrated Care System, the other 2 being Kent County Council and the NHS Integrated Care Board. All integrated care systems in the country were required to produce an integrated care strategy by December last year. That deadline that was imposed upon systems didn't allow much time for engagement. So our local system committed to engaging with the public and with people from a range of different organisations during this year to revise the strategy. The interim strategy was approved by Cabinet in December last year, and since March of this year, we have been engaging in extensive engagement on the strategy. The version that has come to HAS today is the result of much work that has been done to incorporate feedback from people on the strategy. Given that there are 3 statutory organisations that need to approve the strategy, sorting out the governance pathways for this has been an interesting challenge. And as part of this process, we made sure that members of HASC received a copy of the strategy well in advance of this meeting to give members an opportunity to recommend any changes they may wish to see to the strategy before it went to other partners for approval. There have subsequently been a small number of changes that have been made based on feedback that has been received, and these changes have been summarised in the late paper, supplementary paper that's been provided with this item. I'll finish my introduction here, and I'm happy to answer any questions that members might have.
Thank you, David. Members. Councillor Campbell.
Hi. Thank you for that, Chair, and thank you, David. It looks like a very impressive document and very ambitious in what it's trying to achieve, so that's very positive. I have a general remark to make about engagement. I think when I read about engagement efforts, I always worry that the numbers of people engaged are quite low compared to the actual population. And I know when I speak to people out and about, they always say, oh, we didn't even know this was on. We had no idea. How could we feed that in? But I also have worked in the sector, and I know a lot of thought goes into these engagement practices. So I don't know, perhaps there's more work to be done in terms of how we reach out to people and how we make them aware that these things are out, for consultation. Okay, so I have a question around the strategy. I guess I'm struggling to visualize what the delivery mechanism for all of this is. So I understand the ambition, the vision of what you're trying to achieve, especially around things like joined up working between agencies. How will that be evidenced? And what's the actual delivery mechanism? I'm interested in the end user, the service user, and how kind of this all translates to improved services for them, if that makes sense.
Yeah. So if I just may come to the engagement of it first of all, you're absolutely right. It is really important to engage with people, but can also be very difficult. At the same time that we've been developing or revising the integrated care strategy, we've also been developing Medway's joint local health and wellbeing strategy. And through that, we did quite a bit of extensive engagement with people using online surveys and also running focus group discussions with people that we know that would normally not respond to these sorts of surveys, a range of disadvantaged groups. So we put quite a bit of effort in to try and get people's views the best we could, but it's always an ongoing piece of work that we need to keep doing. We will never complete it. We need to always keep engaging with people. When it comes to the delivery mechanism, that's the next component that we're working on now. So we have the strategy document, and then we're taking that through to get signed off by the 3 statutory partners. And we're now developing a joint delivery plan that will be shared between the 3 statutory partners that will take the aspirations of the strategy and turn that into concrete action. Along with that, we're developing what's called a logical framework matrix, which explicitly links the outcomes that we're trying to achieve with indicators that will let us know whether or not we've achieved those outcomes, and then the sources of where we're going to get the information from for those indicators. So we will have a robust and very strong link between what we said we intended to do, the actions that we've taken to try to deliver it, and knowing whether or not we've succeeded.
Councillor Campbell, I think James wants to come in as well.
Thanks, Chair. And just to add, this is a refresh, albeit that the content of it is significantly different from the strategy that was agreed last December. So that there is work ongoing, and clearly I think, because that's your major concern, that we actually are able to demonstrate that things are happening. So I think David reflected on 2 things. One, this is a Kent and Medway-wide integrated care strategy that takes into account a lot of the strategic challenges that we face across the Kent and Medway space. But for us, our joint local health and wellbeing strategy is the primary document that gives us, at least at a place level, the ability to go out there and deliver. And just in terms of some of the structural things, I don't go into this in too much detail, Chair, but we did touch on it in the induction session. You've got different layers. You've got the NHS bit of the system, which has got our acute hospital providers, our community providers, our primary care services, and other colleagues that are actually in that space. You've then got us as a local authority, so we play into that through our adult and children's social care, of course, public health, and also other departments, particularly Medway, our housing, our transport, and other bits and pieces like that. And then, of course, you've got the 3rd sector, voluntary community sector, that also play into it. So you've got lots of different interplay between those moving parts. And for the integrated care strategy, there is, as David's already referenced, a outcomes framework that we're looking at, but you've also got action plans that bring the particular colleagues together for a specific theme. And actually today, we're in this space just talking through some of those elements of some of the delivery that we've been doing. And of course, I will flag, which I will do, sort of the Hypertension Heroes programme, which was Medway born in that kind of sense, initiated here, but has demonstrated real value in terms of reducing the likelihood of our population, but equally people across Kent and Medway, of having strokes and heart attacks. So it is quite, it appears on the surface that it's quite complex, but we are trying to make sure that we can simplify that for the reasons that you've described.
Councillor Campbell, do you want to come back?
Thank you both for that. That does answer most of my question. Just so we understand, in this committee, will we see this document again at some point with those indicators of outcome kind of placed next to it to show the stages of progress?
Yes, absolutely, yes. We'll be happy to bring it here, yes.
Thank you. Councillor Amadishi?
Thank you, and thank you, James, for reiterating some of the points I was going to actually say. In fact, when I was looking at the document, I thought I saw a sprinkling of so many key words like SEO all over the place, and just for my observation, I would have liked to see what values are underpinning the strategy, and that will make it easier for us to then scrutinize. So, for example, there are a lot of key words all over the place, but if I would say, what's the vision, the actual values that underpin it, there's no separate heading for values. It could be every child in Medway must be cared for within Medway, something like that, but there's no values per se in there. So it contains a lot, and when you read on the surface, it looks like it covers all the bases. There's ambition in there, certainly, but to help us scrutinize, to help us hold the ICB to account, as it were, I want to know what the values that underpin it, and I also want to know, in terms of the metrics that we have, at what point will they trigger a response from the team here in the scrutiny to actually go back to you and say, okay, this has been flagged up, what are you doing to address it?
So, excuse me, frog in my throat. With the metrics, the logical framework matrix that I talked about earlier is will be the strategic level tool that will allow us to know whether or not we're delivering on those outcomes. So those will be measures that will be, many of the measures, the data are not available for them very frequently, so they'll be updated probably quarterly or annually. But that's the big strategic vision. Then on the operational side, each of the operational plans will then have their own metrics to tell them whether the delivery plans are delivering what they're supposed to be delivering, and those indicators would be updated more frequently. So there'll be quite a lot of data, quite a lot of indicators that will be made available, and yes, these can certainly come to overview and scrutiny as often as you need to see them. The main strategic documents will be taken to the Integrated Care Partnership Board, which may have a new name now, the Integrated Care Partnership Board, but it could also come here, the metrics can come here as well.
No, thank you for that. Or just to reiterate, a value-based strategy tends to yield better outcomes than one that has no values that underpin it. I'm not saying there are no values, but they're not clearly defined as these are the values that we are adhering to. So as it stands, you can have all these metrics to report, but to what value system, to what vision does that feed back to? So we can hold you to account for, say, recovery. Let's unpack recovery, for example, and it makes the reading of the document so much more digestible. As it stands, it's a lot of information there, but I would have liked to see some values in there.
Okay, so we did have discussions about the different ways we could present the information. The original version was quite a bit longer than the current version, and the strong feedback that we got was that we needed to make it shorter. So we've made it shorter and punchier. I mean, the core value that goes through the whole thing is that the people need to be at the center of everything that we do. It's the people's outcomes that are important, and we need to be thinking about the people as we're delivering the services. So that's sort of the core value through the whole strategy.
Sorry, one more time. I'm sorry to do ping pong. But what does that actually mean? This is why the values is so important. That is such an umbrella term that putting the people center. In health, we've been using that for the last 20, 30 years. Patient-centered care, what does that actually mean? This is where a breakdown of the values will allow you to have metrics that you can be held accountable against.
James, you want to come back?
Yeah, it is a great point. I'd refer probably to, on the document, page 29, and if you look in that space, it sets out the overall tablet and the breakdown of the key areas, and your points that you're making, may or may not be fully answered in relation to those statements in there. So if you look within there, they've set out a vision, which is basically their aspiration for the system. And then they've given each of the different 6 areas. So around children, wider determinants, supporting people to live longer and healthier. And then we've got within those sections some statements that give an understanding as to what we perceive as a system that this looks like. I think the main important point is that this has been created by using engagement with the population. So it may well be that that doesn't come through as strongly as it should do from your perspective in relation to where is this coming from. But it really has been, hence all the changes, being developed with people actually saying this is what we want you to do, rather than you telling us what you're going to do to us. But your points are really well made. But I think on that slide, it sort of then gives you the understanding of the overall principles. And then when you actually go down, it talks about the enablers and how we will actually work. So the ethical framework, which again, I know is really important for you. And then each of the various sections has got the statement about what people have said that they want to hear from us, i.e. us as a system, and then how we're going to deliver against what those aspirations are. I think one of the challenges is getting that middle ground between, you've got a population across Kent and Medway of 1.9 million people, and you never, with all the best intent, going to get one document that will have all of the aspirations for all of those people set out plainly. So I think this is probably as good as we can get it in a strategic document, but I think the principles of how we do the work, which is where I think you're going, that we actually do understand that if we're doing things with people rather than to them, if we're actually listening to what they're saying and reflecting on their feedback, and now we're actually changing our principles. And, excuse me, I will say this, are we actually dealing with inequality, not just of access or of aspiration, but of outcome, which I think is what we've tried to do here. But more of the work, and when you see the log frame, you'll see how we've broken that down, which might be a bit more helpful, give you a bit more teeth, I would suggest, in that space.
Okay, thank you.
Thanks, Councillor. I will be picking that up on my points anyway, so don't worry, I'll come back to that. Councillor Jones.
Thank you, Chair. You'll be pleased to hear that my points have been covered, so I don't have to take up too much of the committee's time. When the officers mentioned the words delivery and outcomes and returning to this committee, that really answered my point. Thank you very much.
We still like to hear from you, Councillor Jones, don't worry, it's okay. Councillor Printer.
Thank you. Mine particularly is just about the support for the workforce. This talks a lot about the support within the workplace for the workforce, but what about outside, particularly those workers who are coming from other areas and sometimes other countries? Is there support for them when they need to find good quality housing, schools for their children? Because I've experienced a couple of cases where people have come and they are literally floundering around. Is there a plan to have somewhere they can go to find that information? And also, I second Councillor Campbell's request to have a more regular update, particularly when it's live and we want to know what the outcomes are and how we're meeting the targets that have been sort of aimed for. Thank you.
David?
Yes, so workforce was a really important part of this developing the strategy. And we recognise that there are many aspects that we need to cover for this. The shared outcome number 6 is about supporting our work, supporting and growing our workforce. And obviously we need, in doing that, we need to cover all aspects. We need to make sure that they are able to work comfortably and have the resources they need, they're able to develop, etc. This is a piece of work that is still under considerable amount of development. We have the workforce leads from Medway Council, Kent County Council and the NHS working together to come up with approaches that will either solve the problems or make things better for the workforce across the 3 organisations, because all of the organisations are struggling to get work, to fill the vacancies in their workforce. So yes, a very key part.
Okay, Councillor. Councillor Brake.
Thank you, Chairman. Just like to pick up, first of all, on the consultation process, which Councillor Campbell picked up on. I find it some very interesting data there, but the couple of things that really come to my mind is, first of all, working with system partners. It talks about the district councils, the Kent Association of Local Council, Voluntary Sector, Kent Housing, the Kent Police and Crime Commissioner. Now I recognise that some of these are areas that we share, but my first question will be, well, of Kent Housing, were any Medway housing associations included in this? I'm just using that as an example, just to make sure that Medway is in fact represented in that area. I was also interested to note that surveys with over 1,000 responses in total, more than half of the responses were from Medway. And that to me really shows that if that's what happened with 1,000 surveys, people in Medway are very interested and probably very concerned about what's happening not only across Medway, but possibly what's happening across the rest of Kent, and how whatever is going to happen, how does that impact on our needs here in Medway? Because that's what people in Medway are interested in. And some of you who are new to the council and wouldn't know that my catchphrase has always been, I'm rather blinkered. I always think Medway, Medway and Medway. Then outside, well, I'll think about that too. But Medway, Medway and Medway is always uppermost in my mind. So I'd just like to get an idea of the responses in other areas from people of Medway. The second point I'd like to pick up on is that looking at on the appendix, the information there on page 4, it actually outlines a whole load of problems that are found, and the way it's done is at Kent and Medway, but there's only one area there, and that's at the very top. It says in Medway and Swale, local survival rates for cancer, in particular lung cancer, are among the lowest in the country. But that seems to be the only one area where Medway is highlighted. What other areas are there of concern that we here in Medway ought to be alerted to? And I'm not just talking about Kent and Medway lags behind the UK and the South East in some indicators of economic success. So I'd just like a little bit more information there, please. And the final point, if I may, please, and that is on page 27 of the agenda, delivering together as an integrated care system. There's talks in there about 1.9 million people. Well, of course, that is across the whole of Kent. But Medway, we're responsible for something like just under 300,000 of those people. So, and there we're looking at all of the staff workforce that is required, GP practices, health and care partnerships, care homes, etc. What I think we ought to really be identifying is, well, how do we fit into this delivery programme for the integrated care system? Because whilst we talk, as an example, we talk about 642 care homes, how many care homes are here in Medway? And what is the situation with Medway care homes? What is the situation with regards to 90,000 staff working across health and care? I pointed out the number of the 1.9 million people. We know that. 90 talks about 13 housing authorities. How does all this go? How does this all link in together? But above all, how is Medway going to be looked after? How are we going to protect the people of our community? Thank you, Chair.
David, briefly, if you can answer that.
Okay, I hope I'll remember to cover all of the points. If I take them in order, so around the engagement, yes, absolutely, we did very well with the engagement from Medway. We put a lot of effort into our engagement exercise to make sure that we got a lot of responses, and we're quite proud of what we managed to achieve. In terms of Medway's profile within the strategy, this is the Kent and Medway integrated care strategy. So it's the three partners together. But we also have, as I said earlier, the joint local health and wellbeing strategy that just focuses on Medway. And that will be the opportunity for us to really highlight all the things that are important for the people in Medway. You mentioned about the 13 housing authorities. That's the 12 Kent districts plus Medway. So Medway is incorporated all the way through here. And I've forgotten your other point, I'm afraid.
So it really was a matter of how do Medway, on this delivery of the integrated care system, how does Medway actually focus, or how do we focus for Medway in the requirements for Medway? You've mentioned part of it by explaining the fact that we've got that opportunity for Medway, but that's down the road. We ought to be doing it now.
Okay.
To be aware of it now.
Dave, James can answer that one.
Okay, thank you.
Thanks. It's a great question. So the simple answer is it depends on how we need to work. So there are certain topics where we do need to have a cross-Kent and Medway-wide view of things, whether it's specialist services, and I'll use a term like cancer, because it's something that needs to be joined up because of the nature of the issue. But what we're able to do then is look at whether our population are actually able to access and get the appropriate interventions and services. But at place level, we've got a number of different ways in which we focus on Medway in itself. So there's some things as a unitary authority, we just do that, and that's within our own gift. But when we start to look at interface with our health and care partners, you've got the Medway and Swell Health and Care Partnership, of which there are a number of officers and other colleagues in this room who are a part of that space. And what that does is it enables us to actually identify various issues, and you've raised a couple in there around, we'll go back to the cancer work, where we can actually drill down on that. We can then engage with the appropriate people that are meant to be delivering those services if they aren't things that are within our direct control, and normally that's commissioned by NHS England. It might be provided by other providers. So I think from our perspective, from a Medway perspective, it's not, this strategy is an overall placeholder for how we need to work collectively across Kent. It's not the delivery mechanisms as we've already discussed, and actually we can get more granular, because when we come into Medway we can then look at our primary care networks within that healthcare partnership and the relationships that we have with those, and not least of course the way in which the council in itself delivers its services and provides through this forum, but also for our joint strategic needs assessment, the actual background to the work that needs to be done. So I would just again remind members, this is not the be-all and end-all for Medway, this strategy. It's a partnership document that we play into that reflects our priorities, but actually we, as a unitary authority, we're able to work in a slightly different way.
Thank you, James. Finally, Councillor Shocker.
Thank you, Chair. First, just a couple of points. Firstly, just on the work and partnership that we're going to be having with the community and the VCSEF. I think we actually, firstly, you missed the F off in the document. It's VCSEF, just put that out. F standing for faith sector now. In regards to that, what is that partnership work actually going to be looking like on paper, and how are they going to be having an impact into the implementation of this strategy? Because from when I speak to a lot of the people in the third sector, they're still saying it, I think, even though they've been given more of a voice in the upper levels, is there seems to still be some cynicism behind the fact that it's just a bit of a tick box exercise for a lot of the partners. And what kind of assurances can you give that they're going to have like an equal voice to other stakeholders within this partnership? And secondly, just touching upon Appendix 2, it was on the Equality, Diversity and Inclusion Impact Assessment, and just more specifically looking at the Gypsy Roma traveller community. I've been quite lucky to be working with this community for the last 5 months, and they are one of these communities that come under the protected characteristic. politics. And this community suffer from like the highest health inequalities. They have the highest disparity in health. So again, same bit similar with this community as well. They have obviously a lack of trust with statutory organisations, and a lot has been promised to them in the past, and a lot of the injustice and the discrimination they kind of face has caused them to have, like, for example, the lowest life expectancy and outcomes like that. So how can we, for the communities in Medway, what can you in fact, are you able to come back with your strategy of what you're looking to do with this community in Medway? And how are you going to be working with the various departments within the council? Because it's not necessarily just a public health thing. This is also connects with planning and other departments within the council for them to actually get the justice and the right levels of health needs that they deserve as a community. So I think I said that right.
Thanks, Councillor Shocker. David, if you can answer the first part, and I can pick up on about bringing items back or sections of this report back. I'm going to touch on it anyway, so that'd be good. I can touch on that one for you. But if you can answer the first one about how we engage, that'd be great.
Okay, yes, certainly. So through there's several different routes. I'm trying to think which one to go through first. So with the integrated care strategy and integrated care system, we have the voluntary sector alliances, and they are represented through the Integrated Care Partnership Board at that level. More locally within Medway, there are a number of initiatives that we have in place. So we are working closely as part of the Health and Care Partnership, the Medway and Swale Health and Care Partnership. Through that, we have developed a memorandum of understanding with voluntary sector organisations to work collaboratively with those organisations to improve health and wellbeing within Medway. And we're doing a number of interesting pieces of work with voluntary organisations as a result of that. And we have representatives, for example, James Howard from MVA, within the meetings, within the Health and Care Partnership as a result of that. There's also some separate work that I'm leading up on doing research in Medway, the Health Determinants Research Collaboration. And a really key part of that is also engaging with the people of Medway to make sure that we are doing research on areas that they think are important and then involving them in the research. And as through that, we have a member of the public who is a member of our executive team. We have a public advisory group that has 6 members of 6 other members of the public from Medway who are independent advisors to our executive team, and 2 of them also sit on our board as well. So we're taking a number of different steps to try to actively engage with the voluntary sector to ensure that they are involved in development of strategy and in development of research and other work that we do.
Thank you, David. Councillor Shock, I'll pick up about how it comes back in a moment. Is that okay? Okay, that's good for members. Can I just ask Emma from Health Watch? I'm not going to put you on the spot, Emma. I'll give you forewarning now. From meetings onwards, I will always ask your opinion on each topic. So, but have you got any comment on this at all that you'd want to bring for the committee's attention?
Is this working now? Okay, thank you. So I am involved in the Integrated Care Partnership, and we've had many discussions on the strategy and everything. And I feel that over the last 12 months, it's really evolved and really developed. And personally, from that perspective, we are really happy with it. We feel that the engagement has been carried out with various members and groups, and especially from the Medway perspective as well, we feel like our voice has really been heard in this and hasn't kind of been dominated from the Kent perspective as it often is. So from a Health Watch perspective, I'm really quite pleased with how this is going on and evolving. So thank you for asking.
Just a couple of quick things from me. When we talk about consultation responses, it would have been good to see some, I think. It comments about some, but sometimes we like to see a bit of the detail. I know James, councillors have said it. I mean, I think it's quite refreshing that councillors are saying they want to see the detail behind the document, because it's not always been the case, and I think it's really healthy when people want to see a bit more behind it. And I think if they if members want to request that, I think it'd be good if they can see that, if they did want to see a bit more detail, because it would make sense. I'm not saying we're going to spend longer here talking about the detail, but if they wanted a briefing note away from this, including, for example, the objectives or proper initiatives and the values, etc., then I think it'd be good to see. The couple of key things for me is the digital services. It says in there, it says very clearly in this strategy, the council and others are striving to go fully digital, yet this document is recognising that IT is not accessible for everyone. Is that going to change our way at the council then on how we're going? We're attempting to go fully digital and probably leaving many people behind. Are we changing our emphasis on our digital access policy in Medway or not?
Thanks, Chair. It's a great question. I think I'd just refer back to that at a place level, what we've got to do is to be really clear about what works for us. And we can take advantage, as we are doing, of whereas partners we're building. And so, for example, we've got a thing called the Kent and Medway Care Record. And what that does is it enables us to all pool data, and it's all been gone through all the data processing requirements, so it's all very safe and secure. But we can then access intelligence on issues that are impacting on our population, but also then baseline and benchmark ourselves against other areas to compare and contrast that. I mean, that's really powerful. We recognise, though, that for certain things, and you will take I see our colleagues from MFT here, there will be certain things where you'd say, no, actually, it's important for somebody to speak to somebody, to have that physical contact, because that's appropriate for this particular cohort. I don't want to put Jackie on the spot, but she's doing quite a lot of work with LD and autism space, so you've got to be mindful that people need to access information or support in different ways. So what I would say would be we need to be flexible as an organisation to think about how we do that. We had a really good session at the last Health and Wellbeing Board where we looked at data intelligence, but actually smart technology that would empower people to be able to take more control, and that's the key thing, where they're able to do that, but equally for us to work in a slightly different way to provide services to people who might need accessing services in a slightly different way. So I'm sort of trying to answer your question to say it would depend on the issue, and it would really depend on the issue, but the trick is digital is not the panacea for everything, and it shouldn't be, and we've got to recognise that. There are a lot of people out there who would not fare well if we just shut everything off and they could only access through a website or a portal or whatever else. But for many people, that is entirely helpful, having the apps, having the tools, having the information, but you've got to have a blended approach, and I think that's where we're trying to get to.
I mean, thanks for that, James. I think what I'm saying is and you've answered it well, I think, you know, there was a time, or there is still a time, where this council is going fully digital. You know, people trying to get their disabled badges, people trying to access their all different means of services on the council. I think if it's in the strategy, we have to be careful what that means for this council. And if we're saying that we recognise people are struggling and not everyone can access, we need other ways for them to do that. And there possibly isn't for things like our disabled badges, etc. There's only one way of doing it. So we need to be aware of that. The other quick point is just about the outcomes. I'm one of these, you know I'm going to say about, I love, and Councillor Amadeshi said the same, and so did Councillor Campbell. These aspirations are wonderful. They're really good aspirations, you know. We can all sit here and say by 2028 the world's going to be wonderful. My only concern is that, which I will touch on, about calling back to make sure we fully scrutinise, keep an eye on this plan. My only worry is because it's Kent and Medway put in together. I don't want Medway's stats dropping because Kent's are better. So Kent's may change and get better. The stats would then say that everything's wonderful, but actually Medway's not improved at all. And Jane, I'm not saying the hospital won't improve, because I know they will, but that's my concern, and that's where I think we have to keep a very close eye on those aspirations about bringing down this, bringing down that, bringing down these rates. I think this committee is going to want to see what that actually means for Medway. And I think Councillor Broke was saying it as well. What it actually means for Medway, to make sure that it's not all all mixed up in them stats. All of a sudden you're coming back to me in a year's time or 2 years' time and saying, oh, look at that, we've achieved that stat, but actually in Medway we haven't. So just for you to be aware, I think we're going to want that breakdown when it comes to it. So members, I think we've got an extra recommendation, Vice Chair. I think everyone has said it. I think we do want the report coming back. I'm going to suggest we bring this back in 6 months. It's going to Cabinet on the 19th, am I correct? 19th of December. Has it gone to HOSC yet? David, has it gone to... Did it go this morning? I can't remember. Did it go there today? I'm not sure whether it's been on. It didn't? No, so it's not been at HOSC yet at all. And I don't know when it's due to go before the ICB either. So I'm going to give 6 months for you to come back then. I think 6 months is a reasonable time for... And what we might do, I will speak to James and Leanne and Jackie. I think the comment that the Vice Chair made around the VCS network, etc., I think if we was to say we bring back one or two specific modules of that strategy and look at it closely, then we can unpick it and we can see what's going on within that, rather than just bringing it all back. That might be our thematic approach going forward, is looking at the strategy and doing some good work on that and looking for those gaps about reaching those communities that we know maybe are never reached by our services, and we'll make sure that's happening. Vice Chair, picking up my recommendation, which I think members have just heard, you can add on with your one as well.
Thank you, Chair. So I move that we note the Kent and Medway Integrated Care Strategy, submit our comments to Cabinet and recommend its approval to Cabinet.
Is that agreed? Seconded, sorry. Is that agreed? I always get that bit wrong. I should have been here long enough to do. Okay, thank you, members. Moving on to item 6. Katie, you're going to do a fantastic job here of giving us all of the items, aren't you, at once, 6, 7 and 8, and you're going to give us the overview and then open for members for questions, but we're going to try and do it in a nice, tight fashion.
Thanks, Kate. Yeah, if you can just give me 1 minute on these. So on the current year then, second round of revenue budget monitoring for the whole council projects an overspend of 12.3 million, which is a 5 million improvement on the first round projections. For this committee, the budget responsibility is something like 110 million. Key pressures around adult social care placement costs, that's on page 75 of your agenda pack, and obviously everyone is working really hard to contain spend within the final months of the year or generate income to bring that overspend down. In terms of the capital monitoring for the current year for this committee, the programme's very small, just a couple of schemes set out on page 96, and there's no overspend projected on any of the areas of the remit of this committee. So then moving on to the third item, the draft budget. So this one reflects the introduction of a new approach to balancing the council's budget, whereby each directorate is working to operate within an agreed budget allocation, and those allocations set out in the report make the assumption that savings or revised assumptions or increased income will be identified that's equal to that budget gap, which is currently standing at just shy of 36 million. Since we produced the papers, the Chancellor has made his autumn statement and the Department of Levelling Up Homes and Communities has published a statement on local government funding. There's not really anything in either of those documents that suggests any additional funding for local government or in fact actually directly impacts any of the projections in our draft budget. But we do expect the provisional settlement will be announced via a written statement on the 19th of December and we'll report to Cabinet in January on what that means for the Council. And the very last thing I'll say is just that obviously goes without saying, but corporate management team and the portfolio holders are working really hard to formulate a package of revised assumptions, proposals to address the shortfall in the budget, and we'll be discussing options with the leader in the Cabinet through the normal budget setting process as we head towards February. Thank you, Chair.
That's fantastic. Thank you very much, Kay. Thank you. Members? Nothing from members from any of the 3 items from the budget? Councillor Shocker?
Yeah, no, I don't think it's so much of a question, but obviously it's my first budget we've come across as a new administration, and it's quite hard. It was quite hard reading, as you can imagine, especially looking at savings of 35 million in the next financial year. So first question probably would be like, what? And it's probably a hard question to answer. What does that look like for our communities in the end when that 35 million is? If we're able to get to the 5 million in cuts, obviously I know how much work officers and the Cabinet have been doing around this and already seen a 5 million saving this year, which is really positive. But obviously from our perspective, the community's already been strained. We've got like a perfect storm with the cost of living crisis and everything that's going on out there. This is just going to be even more unbearable, especially for the most vulnerable families. So my question's not really, I don't have a secondary question to that, but maybe, yeah, I suppose just to find out what that might look like for our communities. From my perspective, yesterday, it was quite funny actually, watching Boris Johnson kind of lying through his teeth. And just to think that we've got a gap of a national funding gap in councils of 4 to 5 billion, but I don't think it needed to happen. So whatever we need to do as councillors, as officers, is to bang on that door, because 4.3 billion was lost in COVID support fraud, 8.7 billion was wasted on PPE deals. You've got failure of test and trace, that's at 37 billion. And on top of that, you've got the cost of Brexit as well, that's another 31 billion. And we're looking at 4 to 5 billion just to make things easier for our communities. So I know what the only thing we can do as a Labour group to help with this is to get, obviously, Councillor Edwards and Khan elected in a Labour government. So up until then, we'll see how we go. But thank you.
Thank you. Katie?
Thank you. In terms of what this budget might represent for our communities, I think it's really important to just note that this doesn't represent a cut in budget, right? So there's something like 21 million of additional resources going into the council services. The problem we're facing is that our costs are rising faster than our ability to raise revenues. And the way that the government expects local authorities to balance the budget is effectively to say, calculate what it will cost you to deliver your services, less what you'll get in grants and income through those services. And the balance is meant to be met by council tax. But obviously the referendum limits effectively mean that we can only raise council tax by 5% next year, whilst most of our costs are rising at much higher rates. I think we've also managed as an authority to balance similar, but not quite so big, budget gaps in previous years. And I think to very limited reductions in the level of service that people are actually seeing. But I will say that we're in quite a different position this year, actually. So closing last year, we had to, well, in the 22-23 financial year, we used about £16 million worth of reserves, and obviously we don't have that again. So it's going to be necessary for this administration, for this organisation, to make some really difficult choices in balancing this budget. But the work that's underway is actually outlined in there's some sections in that report that sort of articulate the kinds of themes that the services are looking at the moment. But largely for this remit of this committee, we haven't crystallised that into plans that it's possible to talk about at this point, or it certainly wasn't at the point at which we produced the budget. I think your second point is really key, right? So we're doing everything we can as officers, and I know members are working really hard on our behalf to lobby the government for not just increased quantum of funding for the sector, but also for a fairer distribution of the funding that's provided to the sector, because since 2016, various governments have been talking about a fairer funding review, which would redistribute grant available to government more along the lines of actual need. And I think we believe that we would get a fairer share of the national grant funding allocations. I mean, Medway is among the 20 lowest funded councils per head of population in the country. So we think that a reshake of that would help us. And I think that's where we've been directing our lobbying efforts to date. Thank you.
Councillor Jones.
Thank you very much, Chair. I was looking at the sort of overall Directorate budget in terms of issues such as recruiting social workers and problems that we've found in the past, and in terms of our partner agencies, particularly relying on migrant workforce. I wondered if the People Services Director has had any thoughts, and she may have a sense of déjà vu about this question, because it's similar to a question that was asked on Tuesday evening at Children and Young People Overview and Scrutiny. Had any thoughts on the government's recently announced immigration measures in the context of working with our partners? For example, whether the 38k salary floor, cutting foreign workers' salary discount and not allowing people to bring their families with them when they come to work would have an impact on social care in Medway, causing further pressures. And I'd be very glad if the director or the finance manager, or whoever's appropriate, could address that question, please, Chair.
Thank you, Councillor Jones. Katie? Okay. Leanne?
Thank you for the question. It's a little early for us to be able to give you a definitive answer for Medway specifically, but you will be aware that what is proposed will impact on the different occupations within the workforce. So for social workers are a registered profession. It is slightly different for them. However, for our care home, our care staff, residential staff, it is likely it will impact, definitely. But I can't sit here tonight and tell you exactly how it's going to impact for Medway, but those professions are certainly in the eye of that policy change. Yep.
Sorry, Chair, perhaps come back when there's more information then. Please.
We certainly can, Councillor, no problem. Councillor Hamadashi?
Thank you for that. My question is to the Council in regards to the monitoring and the evaluation.
Councillor, can you just bring your mic down further, push the mic down further?
Okay, that's better. Okay, my question is to the Council in terms of the monitoring and the evaluation of the impact of any proposed savings and any additional income that might come into the Council. For example, you talk about the proposed changes to the council tax and what sort of anticipated effect would that have on local residents in Medway?
If I may, Chair. So I suppose one thing I'll say is that alongside the budget that's presented to Cabinet and Council in February, officers who are proposing changes to services or have agreed changes to services with portfolio holders that form part of that budget, they're responsible for producing an equalities impact assessment which seeks to try and understand whether the changes that are being proposed would have any adverse impacts on any of the protected characteristics, and that's published alongside the budget. I think perhaps your wider question though is more about how are people going to afford to pay council tax in light of a 5% increase. So that's what the draft budget presents, is that facing the shortfall on funding services that we're looking at, we would need to make the assumption that the council will avail itself of the flexibility to increase the council tax by just under 5%. I think we've calculated that it's a relatively small amount per year, and the number is falling out of my head. It's something like £70 a year on a band D, and it's about 35 pence a week. They're not insignificant sums in a cost of living crisis by any means, but the average band D council tax is about £1,600 a year, Medway's share, so they aren't sort of astronomical increases in cash terms. I hope that helps a little bit. I can get the actual detail of the numbers, I just can't recall it right in front of me, sorry.
That'd be great, Kate. If we could have that extra detail, that'd be really good. Councillor?
No, thank you for that, and I'll come back. Thank you.
Okay, no other members. Vice Chair, sorry to make it very, and unless David, you had anything, or you're happy not to add anything to add? I think Kate is perfect. It's all good.
Thank you, Chair.
Vice Chair, obviously you can lump the three and ask for agreement. We've gone through 3 items, so it'd be good for you just to lump the 3 and ask for agreement.
Sorry, I missed that. What's that?
You can just propose the agreements from items 6, 7 and 8 together.
Yeah, so I move that we agree the recommendations set out in agenda items 6, 7 and 8.
Right. Thank you, Vice Chair. Is that seconded?
Seconded, Chair, with the proviso of something to come back on migrant workers.
No problem. We'll make sure that's noted. Thank you very much. Okay, agreed, members? Agreed? Agreed. Thank you. Thank you very much, Kate. Thank you. Thanks for all your help this year. Thank you. Okay, we move to item 9. Leanne, we've already had a discussion, haven't we, about it's the same. I always moan about the same 2 red items that come back to committee. I will hand over to you, but I think members are aware it is the 2 items that we're always told about. And I have had discussions with the director to maybe look at that as well in the future. And Jackie, I've mentioned it to you as well about bringing those items back and looking at them more closely for us to see why they're always red. I mean, we have had good discussions around why they're red, but maybe look into it a little bit deeper. But I'll still allow you to. Leanne, anything you'd like to add on your document?
Thank you, Chair. I think you're quite right, and it is to be expected to a certain extent that these priorities will either shift or stay the same. That is what tends to happen, but I am quite willing, if you want to suggest one of those two, that we could absolutely bring back a more in-depth, but I do feel that the explanations you've got here this evening are quite comprehensive.
Thank you, Leanne. I mean, I don't want Jackie and James to argue and fight over the two items, but I know, oh, not that you would. I don't want none of that going on the committee, please. Not in Christmas time. I am thinking from members, though, in the past, they would have liked a little bit more about the supported payment stuff and around that. I think direct payments might be an area that would be interesting to look at, because it would give us more detail maybe into all the other stuff we've looked at in the strategies, etc., about how people are struggling. It could give us that little bit more, if that's okay with you. Is that okay with members? Okay. Vice Chair, would you like to?
Thank you, Chair. So I move that we note the Q2 2023-24 performance against the measures used to monitor progress against the Council's priorities, and also note that Q2 2023-24 strategic risk summary.
Thank you very much, Councillor Shocker. Is that seconded? Seconded. Thank you, Councillor Hamadishi. Is that agreed, members? Thank you very much. Thank you. Okay, Jane, the next item we've got here is obviously our update from Medway NHS Foundation Trust. We've got Jane Black here, the CEO. Thank you so much for waiting. We haven't kept you waiting too long, though, tonight so far. Can I just start, Jane, by just saying, I know you're going to give us a short overview right at the very beginning, but what I would like to say, I think it'd be remiss of me this evening not to mention the terrible incident in Maidstone and Tunbridge Wells Hospital with regards to the mortuary and with regards to the abuse that happened there. And obviously, this committee certainly sends all their wishes to the families involved in that. Could you maybe in your report just give us a little bit of assurance that whatever comes out from Sir Jonathan Michael's report, you'll be obviously looking very closely and making sure that we cover that. Is that okay? Thanks, Jane.
Thank you, Chair. I will just bring out some highlights. It is nearly a year since we came, so there have been some real developments, I think, for Medway Foundation Trust. But I will sort of start. I think one of the things I will end on is around operational performance rather than starting with it, because I think there are some challenges that we want to highlight to the committee. But there are some other things that I think are really exciting for Medway and Medway residents. So I'll pull out some of those things. I think some of the key things, and actually listening to some of tonight's conversation, if I just draw on particularly around our cancer performance, we had been doing really well around the cancer performance, but highlighting the fact that we do have a limited capacity around endoscopy. And that actually is our Achilles heel. But actually, we've put some measures in place. We have been given some funding by NHSE for some mobile units, which we've been successful, and they will be going in, which has been really important. But that relates to the point that Councillor Brake made around the sort of population needs and the cancer rates. And that's really, really important that we get that moving and reduce the waits in terms of endoscopy, whether it's for cancer or whether it's for routine. So that's really, really important, and it's part of our strategic plan. And at the end, I will just briefly mention about the clinical strategy that we've just going to take to board in January. With that, we've also, around diagnostics in particular, you would know that we've actually put a community diagnostics hub into Rochester, and there will be another one going into Sheppey. And also we gained funding from NHSE again about some of our plans going forward, but developing a cardiac and respiratory village. And as you've pointed out, you know, around some of our population needs around respiratory and cardiac problems, that's really important to us. So we actually start digging, as they say, over the next few months. So we are going to be refurbishing, and then we will have a cardiac and respiratory village going into the latter end of next year. So those things are really quite important. As most of you know, I've talked about this before, that we are a very emergency-driven organisation. We are a single site predominantly, which does cause us a lot of problems being one site only. And particularly as we go into winter, as we've seen over a number of years, that actually our elective capacity is often impinged upon. And that's when we start having to cancel, because of emergency admissions, we have to cancel elective patients. What we've done over the summer, and part of our strategy, is actually we were able to refurbish a ward, which is Harvey Ward, which has now become our orthopaedic 25-bedded ward, but that released capacity in other beds so that we could actually do more work through our elective caseload. But also that's enabled us to use Sunderland, which is our day case area. That was always bedded overnight and would have patients in for a longer length of time than just day surgery. We have now opened that up, and we are driving very hard to reduce our waiting list. So that's really important to us. And going forward, we need to find a solution. We need to find a solution so that we don't impinge upon the elective activity. And there are a number of things on the table that we want to explore, working with our health and care partnership, but also particularly with the council around how we could do that in the future. Just as a point around our productivity around theatre, we have been doing really well, and we've got one of the best in the country around theatre utilisation through the patient first work that we've been doing around our improvement. So we're going in the right direction. We're not quite where we want to be with things, but it is getting there in terms of elective. But we are seeing a reduction, particularly in some of the areas around our elective care. Just a little bit just around finance. You've just talked about finance. And for us, we remain in what they call soft 4, which is whereby we've been in soft 4 for a couple of years now, which is like special measures. For all the other measures that we were put in for soft 4, we have been signed off. The last one is finance. And as you well know, we have been challenged. And actually we agreed a control total this year of £15 million deficit. Unfortunately, due to a number of things, including industrial action, there have been, we are over that. At month 6, we are at 22 million. So we are working with the system and with our ICB to reduce the run rate as we go towards the end of the year. But it is extremely challenging. And actually, a lot of that is to do with the additional capacity, which I'll talk about in a minute, that we've had to put in place in order to improve patient flow. So there are a number of things that all fit together. Our drive is for improvement. Patient first is our driver. That's our improvement methodology, but it's also about a change in culture. It's a change in the way that we do things, and that takes time. Out of our 5,000, just under 5,000 staff, we've now, in 1 year, done 600 people trained in that methodology. And so we are starting to see some of the improvements that we want to be able to show you. So much so that particularly in emergency and acute care, they have been up for 2 awards around the Health Service Journal and also the Parliamentary Award for our area, and also around Nursing Times. There have been a number of really good successes through that, and we just have to keep building on that, which is really important. So a lot of work is being done through Patient First and around our culture and how we do make sure that we are doing the right things. I think the biggest thing, just lastly, really, is around our operational performance around emergency care. Now, we started to see some real improvements, and you will see from the paper around the ambulance handover. We started that piece of work probably last year, and we have continued around 60 minutes, but not only 60 minutes handover, but 30 and 15, as being one of the best in the country. We do offload patients. It's really important that we do that so we do not hold up ambulances. That wasn't the culture that we had probably a year or two ago, but it is part and parcel of what we believe is the right thing to do. So it's great that we can do that, and we will continue to do that. But what we've seen, particularly over the last few months, is we're becoming more challenged. You would see in the paper we are about 100 beds short. We know that. Several people outside of us have told us that. And actually the work that we're doing as part of the Health and Care Partnership is really important. So the discharge monies that we received last year as a Health and Care Partnership, we've been working together to make sure that we can do that. We actually, as part of that discharge piece, in October, and thank you to Jackie actually, she's been working really hard with us around Amherst. So we've opened up those 40 beds. We're not quite full yet, but we're getting there. And thank you, Jackie, I do appreciate it. But we are starting to see, to compensate, we don't have to have all of the beds on site because we're 100 beds short. But we do need to make sure that we've got capacity so that we can be able to do the right thing around our patients. But what we've seen over the last couple of months is not something that I want to see our organisation continue with. And internally, we are doing a huge amount of work to ensure that patients flow from ED through our departments and make sure they have a good discharge. But it has been extremely difficult. And you would have heard about patients, unfortunately, that have been in the corridor. I have to apologise for that. It's not the care that we want to give. It's really important about the fact that we now work really hard to solve some of that before we get into the depths of winter, really. And particularly for me, it's around privacy and dignity and patient experience. So we've got a lot of work to do. And actually, our partners are also helping us in terms of doing that, because we are seeing quite a high rate of no criteria to reside patients. We have been up to 150. And so together we are trying to work to make sure that we can reduce that number in a timely fashion, but recognising all of the challenges that each of our partners have as much as we do. We have put in some real initiatives. You will see in the paper around teletracking. That is a electronic bed system and flow model. I can't tell you how the difference. We've just seen 6 worth of data that shows the metrics and the improvements of our turnaround times. And I'd be delighted to, at some point, come and show you some of that once we've got further on. But I can't tell you the difference of being able to do it electronically and not on a bit of paper. So it is certainly something that is the right thing for us to have done. But as I say, we've seen activity increase, and that is up to about 17%. So we've got to do things differently. So we've got to react differently. And so that has been quite challenged. But I think I'll probably leave it there, but I'm happy to take questions. So thank you.
Jane, just on the mortuary bit, you'll be taking...
Oh, sorry, mortuary.
You'll be taking
absolutely.
You'll be taking any recommendations?
Yeah, no, absolutely. So, I follow your sentiments completely. It's not what we would want at all. We have done a lot of work. When the initial report came out, we actually did a analysis of what we had in terms of access, of who was able to get in, and put in a number of measures and strengthened quite a lot of measures. We've actually discussed that at our trust board, and we will continue to monitor, but I can assure you that we have put in, and we are confident we've got the right things in place.
Thank you, Jane. Members. Councillor Amadeshi.
Thank you very much for that report. Just two very quick questions. The first one is related to elective surgery, when you talked about the ongoing strike for junior doctors and consultants, you know, so you haven't reached your full potential in terms of what you want to achieve there, but still you had 108% performance of electric surgery compared to 2019. Most of the strikes were to do with pay and working conditions. So could you inform us in terms of the conditions for the junior doctors and consultants? Have they been improved so that we can mitigate against this the following year? And also, the second question is to do with the patient flow system that you adopted, teletracking. Teletracking patient flow is a system that's been around for many, many years. And what was the delay in Medway having a patient flow electronic system? Yeah, thank you.
Shall I do teletracking first? What was the delay? I've been there about 2 years now, 2 and a bit years. I think some of it was probably funding. I think also we haven't really had a strategic plan for a few years, and I think this is part of our strategic plan that we would put this in because it's, you know, we need to come into the 21st century, I think. So I think for us, it was about understanding. We went over to Maidstone and Tunbridge Wells where they had it and been to other areas, and it seemed the right thing to do because, you know, doing it the old way, we could see that we were delaying patients and actually, you know, it's so inefficient. So I think the delays, I think, it was around funding, but we did put in a number of bids to get that funding, and there was an opportunity to do it, and we were lucky to get that funding from the centre so that we could go ahead with it. So that is getting the opportunity to do it. But it is certainly making significant difference in terms of patient turnaround and when the bed's available and then when we can move people. But I think with that, we've still got to do some work internally because we've got long waits in ED, far too long. And there are other things that need to relate to that, both internally and externally, that we need to work on. So I think it's great that it's here, and be delighted to show you some of that. I'll bring one of the experts with me because don't ask me the technical questions. And just around the doctors and junior doctors and consultants, obviously everyone's got a right to strike. This was more around, you know, that's a central thing for the government to sort through. From my point of view, this was more about making sure that we kept patients safe. I have got to say that our medical teams, regardless of the fact that they are striking, have been absolutely fantastic. Because if you think about, you know, particularly if the junior doctors have gone out, the consultants are picking up all of those shifts and doing that. And they've worked really well with both the executive but also operational colleagues, nursing colleagues. And so for us, the industrial action, it has been quite challenging. I will say we've got another challenging period now coming up over a very difficult time. So we are planning now and working with colleagues to make sure that we keep patients safe.
Thank you for that. Well, just in terms of the conditions, is there anything about the conditions?
It's the terms and conditions. It's not necessarily the conditions of where they're working. It's the terms and conditions of their pay. So that's certainly from what they're saying to me is about their working conditions in terms for us is about making sure that, you know, they've got their job plans, that we're supporting them with any development that they need, etc. And I think that is what is in place. And the same with junior doctors. You know, we gained more junior doctors this year. We were lucky enough to have additional junior doctors. And we regularly have reports through about the conditions of which they're working, how they are and what they are. We have got some challenged areas which we are working with them. So I think it is around some of that, but happy to share that at a different date. But the strike is about, it's about the pay.
No, okay, thank you.
Thank you, Councillor. Councillor Campbell.
Thank you, Chair. Thanks for that overview, Jane. And I just wanted to start by saying it's really great to see the recognition that your teams have already received in terms of the awards and nominations. It's always great to see that, putting Medway on the map, as it were, with all the improvements. And I think some of that recognition has come amid some insane challenges like you've just described. So it's extra congratulations for that. Just for my own understanding, you talk about NCTR, and you mentioned that as well. Could you just tell me what that is, NCTR is, and how
No
is that being-
criteria to reside, so it's another term for delayed discharges.
Okay.
So what we do, and Jackie's looking at me, I can tell, is once a patient is fit to be discharged, then the clock starts in terms of saying, actually, they shouldn't be with us anymore. They should be in a different place. So it could be that they need to be discharged home, just with something, medication or whatever. It could be, you might know the terms, pathway 0, 1, 2 and 3. So that's what we're referring to. So it's around those patients of delayed either 0. 0 is our responsibility in the hospital. They don't need anything. We just need to discharge them and discharge them in a timely fashion after they've been cleared to go home. Pathway 1 is more about having support at home. Pathway 2 is around community beds or community support. And then the third is around sort of care. So we monitor on a regular basis. Actually, as a health and care partnership, we can see that on a daily basis, and we can see who is waiting, how long they've waiting, and what they're waiting for. Does that help?
Thank you. So I'm curious as to what the solutions are to the pressure that's caused by the NCTR.
They're quite broad. So you've already talked about some of the longer term strategic things today. Is about some of this is around prevention and what we can do out in the community in the first instance. I always think by the time people have got to us, obviously, if you need to come to hospital, you need to come to the trust. That's absolutely right and proper. But sometimes I think all the work that we're doing as a health and care partnership is really important about prevention of admission and what can we do. And so, I don't believe our place is always the best place for somebody, but we end up being the place of safety. And so, or by that point, someone needs to come into us, and that's absolutely right and proper. So I think there's work that we need to do together. So that's part of the solution about prevention and what else we can do about hospital avoidance. And I think we are doing some fantastic work already, but we need to do more. I think there is also something around, unfortunately, again, Jackie has to put up with me every couple of weeks as part of the Health and Care Partnership, looking at our discharge and our discharge processes at a high level. And we look at that to see if we've been using the discharge monies that we've been given effectively, and if not, then what do we do about it? But I think there are other solutions that we need to be putting in and really working hard about what's the community model that we need to have out there that supports people, either stopping them from coming into us, but also then how can we discharge effectively. So I think there is some room for, we need to do more around that, and we need to do it together. And I do recognise you do have another item probably after us, but it's really important we get that right. And we need to shape that because we know what the population needs. And it's important we do it together as a health and care partnership to really understand what that model looks like and how we can do it. Because actually all the while that we don't take that next step, patients will continue to keep coming into us, and actually we need to make sure they're in the right place the first time.
Thank you for that. That does make sense now. I just had a quick question
Councillor
about...
Campbell, I think if Jackie just comes back with you as well, and then you can come, she's following on from there for you.
Yeah.
Cool, yeah, thank you. Just to sort of
sort of concur with what Jane's saying about how we're working together, and it's fine that we meet fortnightly. From a social care point of view, we've got a real problem in Medway at the moment, and actually across Kent and Medway, with the number of beds that are available in care homes. So if I give you an example, the information that I received today showed me that I had 1 bed available, so a council contracted bed, 1 bed available in the whole of Medway. There's 65 care homes, Councillor Blake asked earlier on, so out of those 65, 1. What that means then for Jane is that when somebody's ready to be discharged on pathway 3, my social care team haven't got the ability to move the patient out. We were awarded some funding recently, and Jack's at the end of the room there has been working really closely with a care home provider in Wigmore, and we've used that funding to secure some assessment beds. Because what we don't want is people to come out of hospital really and move into long-term care. What we want is to be able to see actually at that period of assessment and determine from that point what their long-term care needs are. So can they go home? Do they need to go into a permanent care home? So Jack is looking at how does this work over the next few weeks. Now we've got this funding and these beds available, and if it's successful, putting a bid in to get some additional funding so we can expand that. It's a problem nationally, but I think particularly in Kent and Medway, it is a real challenge.
Leanne as well.
I just wanted to say that the local authority does take its responsibility very seriously around this issue. Jackie and Jane are working all the time, but Jackie once a week reports through to me for any patients that are still in hospital longer than a 10-day period, so we can absolutely focus down and pull all the levers we need to pull to shift things in the best interests of the patient as well as the trust.
Thank you, Leanne. Councillor Campbell, your final question?
Yeah, thank you. It's a very worrying picture, isn't it? I can see that you're all working in coordination. It's a very worrying picture. But thank you for answering that. I have a final question about MEDOC. MEDOC is mentioned here. So am I right in understanding that MEDOC, people who go through MEDOC, it impacts your numbers, your statistics of how people go through ED? Is that correct?
So MEDOC obviously is run by MCH and working in partnership with us. Yes, they're counted in our numbers. They are counted in our daily numbers. And actually we've got pathways that interlink between that. So if someone comes into us, for example, and actually we deem that actually they don't need ED care, they need MEDOC care, then we will, we've got a relationship and pathway that actually sends them around to that, and vice versa. So that's really quite important. We have that because that's an urgent treatment centre approach, which is the right thing to do. So patients will be triaged either way to identify whether they're in the right place or not, but they do count in our numbers. We're a very busy site, with MEDOC and with ourselves. Having worked, in health service for a long time, this is one of the busiest EDs that I've looked after.
Thank you.
Thanks, Councillor Campbell. Councillor Mark Printer.
Yeah, thank you. I did have a number of questions regarding industrial action, but they've already been asked. Just around the industrial action, I was on a strike yesterday myself. It's not a decision you take lightly to withdraw your labour. I'm surely not in the medical profession do they take that decision lightly. One of the frustrations of our industrial action is the non-negotiations taking place with the government and wanting now, where we have medium employers, to actually go to the government and say, negotiate for us. I know you don't negotiate yourself, but are you making their representations to the ministers to say, these are the pressures we're under, this is what's affecting our staff, can you please negotiate with the junior doctors, which are the only ones left?
So we do that through the central team. We're very clear. I think we've been clear about the impact that it's having across the piece, not just at Medway, but certainly from our perspective, the impact that it has, and you can see that in the number of patients that we have to cancel and then try and rebook. But it's not just about that on the day. It does have a ripple effect, and so and it has a significant impact on the workforce. We've had a number of strikes now, and actually if you think about that impact on the workforce of having to do something different each time, and either not do the normal work that they do, but they, you know, emergency comes first. We try to protect the cancer and urgents, which we do, patients, but it's the impact on the workforce, I think, which is a really big thing. And we have to look after them around that because it is getting harder and harder. We do make representation, and we do that through a number of routes, through the ICB, but also up through region and then to the central team. And I've been part of the chief execs where we've met with Amanda Pritchard, for example. We can't negotiate, it's not our role to, but we certainly play, and you would have seen in the press that she has talked about, you know, patient safety and raising those concerns.
Thank you. I'm pleased to hear that, but also commend to the staff who do make sure that critical services do carry on, even though their union or organisation or association is on strike. So thank you.
Thank you, Councillor Printer. Councillor Shocker.
Thank you. So first one's just an observation, really, regarding a good discharge, as you mentioned, and probably pathway 2, which I've just had recent experience with. There's a lot to live up to in terms of expectations of pathway 2, in terms of Britain House, for example, when patients are being discharged, Britain House are not picking it up. I've noticed that from a family member. Other people in the community subsequently, after investigating with them, have had similar experiences. So I think that's quite an important one. Obviously, you don't have the mental health ward or facilities within the hospital. What's ended up happening, you're getting people coming back because they're not being picked up in the community. So that's just more an observation. And secondly, is a question, on the next report, would it be possible to maybe have a report on your patient advice and liaison service? So we can see what type of complaints you're getting in, compliments you're getting in, and concerns, and how they've been investigated and what the outcomes are. Yeah.
Question. Thank you, Councillor Shocker. Councillor Jones.
Thank you very much, Chair. First of all, I think we should comment positively on the ambulance turnaround times. If that is working, you know, we should say, you know, this is a positive and welcome it. In terms of the urgent care centre, I don't know whether you have this sort of statistical data now, but you might have some anecdotal feel for what I'm about to ask. But I do recall one of your predecessors commenting, I can't remember the context of the question, but she commented that if people were turning up a number of times at the urgent care centre, there was something wrong because things weren't being sorted on the earlier visit. I don't know whether you agree with that comment and whether you have a feel for whether it's part of the workload that you have to cope with in the urgent care centre. The other point I wanted to make was, the second and only other point, Chair, was your comments about the endoscopy. I welcome, you know, extra community facilities, which I think is what you said. My experience with a recent endoscopy was quite quick in terms of getting there. Had a considerable wait when I got there because the surgical staff were having to take a number of samples for biopsy. Now, I realise you can't plan the patient. I don't know quite what you do about it, actually. You can't plan the patient list on the assumption a patient is necessarily going to take 3/4 of an hour or an hour. But you know, is there a timetable for the additional facilities you mentioned? And might these extra facilities help resolve the question of waiting times? Thank you very much.
Just in terms of the UTC, if someone keeps coming back, then I think, you know, that should be an alarm bell for the team that is seeing them, and have we done everything that we should have done? I mean, I think that's the sort of way that we should be going. I think the other thing around UTCs, and particularly for Medway, you know, we see a lot of patients that probably don't need to come into us. because they can't or they haven't been able to see a GP for a period of time. That's not blaming primary care, but there is something as a health and care partnership again, and working with the ICB, that we need to try and resolve, and what could we do differently and help support primary care. And I think that's really quite important, and that's something we've got to carry on doing in terms of over the next year or two. Because we do have a lack of GPs, and therefore what else could we do differently? But I think around the UTC piece, it's about, you know, I'm sure the alarm bell would go off if you come back 2 or 3 times and we're not resolving it. We should be doing, you know, something to understand why. But we do see that people come where they could be treated somewhere differently. So we need to take up those other options around, you know, pharmacy and all that sort of thing. Because people can't get a GP appointment, or they've left it quite a long time. And you can understand why sometimes. So I think there's a mixture there in terms of that. In terms of endoscopy, Medway have only had 2 endoscopy rooms, which for our population is, we need 5 at least. And so one of the things we've got a business case that looks at additional on-site here, but also I think the opportunity strategically to do something different out in the community is really important, and that would give us additional endoscopy rooms. So that is the strategic plan that we want to be able to do through, if we can, and I will say this, is through an elective hub, a local elective hub, which is really important, and that would provide a number of facilities, including endoscopy. But in the short term, while we're trying to sort those things out, we have been successful in terms of getting those additional mobiles, and that will start to reduce, and we're starting to see that, the reduce in the wait for endoscopy care. So that's really quite important. I have to give a shout out as well for Dartford, because Dartford and Maidstone, Tunbridge Wells have supported us and offered patients, so they didn't have to wait appointments if they wanted them. So you know, that's a short-term fix, but actually it's important that we don't let those waits carry on. We've got to do something while we get the longer-term plan. And the longer-term plan is our clinical strategy, which we have been doing over the past 6-7 months. It's going to our board in January, and I've said to the chair about bringing that here so that we can talk that through, because that's a 3 to 5 to 10 year plan about what we have been working with our clinicians and external stakeholders about what we want to do in terms of Medway.
Thank you for the comprehensive answers, Chair.
Thank you, Councillor Jones. I've got Councillor Llewellyn-Printer, Councillor Brake and Councillor Clark. So, Councillor Printer.
Thank you for the report. Thank you for going over it. I've spoken before, Chair, about discharge, the delays to discharge from Medway Hospital. I've seen firsthand the pressure on the emergency area and beds in corridors, elderly waiting there for 24 hours. It goes on. I know we've spoke about having care packages in place and the delays Jackie mentioned with only 1 space available in a care home. But there's also pressure within the hospital, I believe, under pharmacy, and the delays it takes to get medication down to people waiting. I think in the lower area of the hospital, the area where they're waiting to be discharged, so they're medically fit but they're waiting, that could take hours and hours, sometimes overnight, for just medicine. So that's another bed, excuse me, that is being taken by somebody who doesn't need to be there. In the previous administration, I believe, would have closed this place, but there was a place in Gillingham called Shoulder House. I don't know if you're aware of it. It's now university accommodation, but that was a place where, excuse me, the elderly could go for rehabilitation on leaving hospital. So if they had stairs in their own home, but they needed to learn how to walk up and down the stairs again, they could free up the bed in the hospital and go there, and it was sort of semi-independent living for a short term of a week or something. But now that's been closed, is there a view, Jackie might know that more, of having more of that in the local area for just a sort of halfway house, so to speak, for the elderly in particular to be leaving and freeing up beds, because there are, as you say, many that are fit to go. The other thing I think is to Jackie, you mentioned private care homes in Wigmore that are getting paid.
Judge, I sort of referred to some of the improvement work that we're doing internally, and particularly around pharmacy. Pharmacy actually were one of the areas that were up for an award. So actually the improvement work that they've been doing has been really significant. But actually, once you get the prescription, if you like, down to pharmacy, they turn it around very quickly. And actually we can see that. So it's the processes that come before it. And so the work that we are doing with the clinical teams and with the process, it's more around that than it is actually around pharmacy. They just seem to, get the brunt end, if you like. It looks like they're blocking it, but actually once they get it, they turn it around pretty quickly. And so actually it's all the work that we need to do with the clinical teams and the process, and that is what we're working on at the moment. So it's really important that we get that right. So, we're working on things where every patient must have a EDD, as we call it. So that is about a discharge date, so that everyone knows, the patient understands when we think they will be discharged, and also everyone knows when they will be. So that's really important. The next bit is about when actually the prescription, if you like, is being written. And actually we can start doing some of that work. We don't need to wait until the final day for that to be done. So there's work being done with the clinical teams in order to improve that process.
Jackie, do you want to add on?
Thank you. I can't comment on Shoulder House. It's a little bit before my time. So, but what I will say is there's a slightly different approach with our intermediate care service. Councillor Shoki spoke about Pathway 2. So sometimes that can be that somebody comes out of hospital, goes into a bed in the community and receives some rehabilitation in that bed for a period of time. But the change that's actually taken place is that we provide rehab in people's homes as well now. So they can be discharged from hospital, go home and have some rehab, or they can go back to their care home and have rehab. And what was happening previously was they may have to go to an assessment bed and then back to their care home. That's really early days, so there's analysis and monitoring at the moment to look at how that's working. With regard to should we be looking at something ourselves, that piece of work is actually underway at the moment. Whether that's something that we deliver as a council or whether we deliver as a partnership, that's what we're doing some analysis, looking at what's needed in Medway. Is it needed? What we've also got to look at is from a social care perspective, are we delivering the right care at the right time for people? So there's a whole piece of work going on in adult social care at the moment, but we call it Care for Medway. That is being reviewed and looked at the moment.
Thank you, Jackie. Thanks, Councillor Printer. Councillor Brake.
Thank you, Chairman, and thank you, Jane, for your presentation this evening and also the report. I do have one specific point to raise, but before I do that, I will home in on the patient first strategy, which I know has been something that was been very close to your heart when you came to Medway. And as I recall, I scribbled it down, and I hope I got it right. The mission of the patient first was best of care by the best of people, providing excellent care every time. I think that's about right, isn't it? Yeah. Well, I think that's where patient first comes from, and the objective of MFT, really to look after everybody that goes through the door, whether they come from Medway and or Swale or any other areas that they come to. And I congratulate MFT for the hard work that's been put in there. Also congratulate both you and Jackie and the teams for the way you work for the discharge and getting as many people as you possibly can out of the door and back home. Because certainly when I started as a councillor and involved on the health side, it was made very clear to everybody that, particularly by the medical staff, that the best place for a patient to be is not in hospital, but out of hospital, and usually back home in the care of family and or professional carers. And I've always followed that one through. But the more specific point that I wanted to ask is that early in your presentation, you made mention of some of the work that's going on across Medway to improve upon services. And one in particular that you mentioned was the cardiac service. And you were saying that, well, we're doing some work now, but by the end of next year, and crikey, here we are, we're coming up to the end of this year. So this time next year, we ought to be sitting here and you ought to be telling us that, well, we're nearly there, or it'll be another few months. It worries me that we're having to wait until the end of next year before that particular piece of work has been completed. Can I ask, in the meantime, what are we collectively doing to look after those people that do need cardiac attention, whether it be examination to see if there's anything further is required, or whether it's no more action is required, or indeed somebody who may be in a serious situation that could require immediate help. What are we doing to make sure that those people are not being overlooked, please, and not having to wait until the end of next year? Thank you.
If I put it into context, when I talk about the cardiac and respiratory village, this is a capital programme. So this is about redesigning, not the processes and things, this is redesigning the facilities that we're going to provide for both the cardiac and respiratory patients. Because at the moment, they're sort of scattered across the hospital and in different areas. And what this provides, and it's something the clinicians apparently have been asking for about 15 years. If you ask them, they have been asking for it for a long time. We were able to secure and were supported by ICB and to NHSE to get the capital funding in order for us to start doing that build. So that's really important, and that provides additional facilities for both of those specialties, and it helps us co-locate and improve the flow for patients. In the meantime, we haven't taken our foot off the pedal. In terms of cardiac patients, for example, they've done a huge amount of work using Patient First to reduce the number of waits for patients waiting for outpatients, for cardiac procedures, etc. They have done a huge amount of work and reduced the waiting time. So we're not taking our foot off the pedal. This is about the building work takes a period of time to be done, so it won't be until sort of into the latter end of next year that we'll be able to move people into those facilities and be able to then co-locate people and do that. So just to give you some assurance that it's not, when I talk about the cardiac village and the respiratory village, it's about capital, it's not about the processes, because we're working on them all of the time.
Thank you, Dick.
If I could just come back and thank you for that information. Not wishing to prolong this, a resident in my own ward actually came to me and asked the question. And it appears that she had been to see her GP, and the GP had in fact said he would request an appointment for this lady to be examined to ensure that everything was in proper order, or what else may ever be needed. And the lady explained to me that she then received, some 3 weeks after her appointment with her GP, a general letter saying, please, if you're capable, please go onto the website and make an appointment. And this lady tried to do that. It wouldn't recognise, well, it did recognise a reference number, and eventually she finished up speaking by telephone after a further 2 weeks of trying unsuccessfully to get an appointment, and was told, well, there doesn't seem to be anything available in Medway at the moment, or any of the other hospitals. Keep on calling back if you wish, but we've just got to wait until we can get some appointment times, and then we'll be in touch with you. Now, that appears to be something like nearly 7 weeks ago that this lady had this. I initially suggested this lady should contact the PALS system, but as you're here this evening, and you did mention cardiac and respiratory facilities specifically, I'm using this as an opportunity to actually ask the question. Something's gone wrong somewhere because that doesn't really conform to what I put down and read out, and spoke about, patient first.
So, as you know, the work that we are doing is reducing those wait times. And, you know, because of COVID, we did see extended times for routine patients. One of the things that should happen, and, you know, I can talk to you outside about some of this, but around that lady. But we need to understand whether she's an urgent appointment or whether she's a routine appointment. Routine appointments, unfortunately, have got a long wait. But as I said, with cardiac, we have seen those wait times come down. So they were up, as you would have seen nationally, but you can also see our waiting times. They were up towards, because of COVID, were up towards 65 weeks. Some of them were going up to 78. We have reduced all of those. And this year, certainly we are concentrating on our specialties and reducing our wait time under 65 weeks. Not every specialty is at 65 weeks, and we're then going down to 52 weeks. So, however, it sounds awful when I talk about those wait times, but they are large volumes of patients that we need to make sure we're giving appointments to. So it does depend on whether she's urgent or routine, but happy to talk to you outside.
Thank you, Councillor Brake. Thank you. And finally, Councillor Clark.
Thank you, Chairman. Thank you, Jane, for this evening. I just want to pick up on the Medoc that Councillor Campbell briefly mentioned. Most people obviously end up there because they've gone through A&E. The nuance of the fact that it's not the hospital providing that service is probably lost on them. Anecdotally, and from my own family, the experience that you get there has been pretty dire at times, and often there's only been one or at best two doctors available. You mentioned in 411 that you're working with the provider to support improvements in this area, but how much of a priority are you making that, because it's not the hospital? But bear in mind that many residents, that's the experience that they're taken away from, and it is quite traumatic. I had one recently, a resident who'd spent several hours in A&E, only then to be parked in Medoc for several more hours to wait to see a doctor, and having seen many people pass through because of the way that corridor's configured, who were obviously medical people, but nobody could help because they weren't part of Medoc, which again, if you're there in that position, seems absolutely crazy. So I wondered, if it is not being made a priority, what the hospital could do to make that so, please.
So the work we're doing around emergency care actually includes Medoc. Obviously, as I said, it's not passing the buck. It is run by MCH. But it's important that we get those pathways right. It absolutely is a priority because, as I said to you, we have got issues around emergency flow. And so we have to get that right. And so part of the work that we're doing, whilst we're doing work internally, my Chief Operating Officer and the staff that work with him work very closely with Medoc. Certainly we want to have a closer relationship. We want to be able to have better pathways, and I think that's what we're working on at the moment with them in terms of how that looks. And one of the things is that, you know, I don't want patients to have a long wait because they've come into ED and then have to go around to Medoc because they're deemed to be the right place for them. Actually, what we need to do is look at some of that streaming going straight into Medoc. And so that is part of the work that we're looking at. And my executive colleague, Chief Operating Officer, is doing that. So it's part and parcel of the work that we need to do. What we do see is that, and I can't speak for them, but they do have staffing issues at times, and that obviously has an impact. I think there is an opportunity for us to work with them much closer. And whilst we have workforce challenges, it's about how can we improve that flow between the two organisations.
Thank you. Chairman, so do the hospital ever provide additional doctor resources to them then on nights where they've only got one person on? or is it even if you've got more available?
We have offered to support if we can. It's not that we won't. It's often we are busy. I suppose if we had the opportunity to, we have offered to support if they've got workforce issues, but it's not a routine thing. And I think more work probably needs to be done around that. And as I say, the sort of working, it's difficult for us to release doctors when we are under so much pressure. So I think probably more work. I'm not stalling, I'm just trying to think it through in terms of we have offered in the past to support when we know that they are really short.
Thank you, Jane. Thank you, Councillor Clark. Leanne, you've got a question.
Thanks. I just, page 142, 143, I just wanted to draw the committee's attention to safeguarding because, Jane, I want to thank the Trust and congratulate you on taking safeguarding so seriously. You know, absolute training. I note on 9.4 level 3 is down around 50, but you know, I am sure you have plans afoot. But you know, as a partner around safeguarding, we can't do it without your support. So it is very good to read this. And I particularly want to congratulate you on 9.10. Not very many trusts absolutely get their responsibility around safeguarding children, particularly around strategy meetings and working together guidance. So a bit of positive back to you and the Trust, but also I wanted members to understand that this is absolutely key in terms of the local authority's responsibility around safeguarding adults and children. So thank you.
Can I just come back about level 3? Thank you for that, Leanne. I appreciate that. There is a lot of work and we take it very seriously. Just around level 3 is we've redesignated who does level 3, and so that's why the percentage is down lower at the moment, because we've got a larger cohort that we've got to get through. So but we've got a trajectory that we will meet.
Thank you, Leanne. Jane, I normally have a load of questions for you, but because I've got a wonderful committee, I've ticked off most of them because everyone's asked the questions. But I do have a couple which are the standard ones I would ask you at this time of the year, I suppose, and normally do. And I suppose the first one's about the winter pressure. So you're from what you said right at the very beginning, you're struggling now down in A&E and emergency with a higher bed. I presume with you haven't got many beds available at certain times. So how prepared? The question I normally ask you is how are you getting prepared for the winter pressure? How is it now? How bad is it now?
It is challenging. And I think over the last couple of months, as I said, but particularly these last few weeks, we have seen ED under extreme pressure. With that, we have had to open our escalation areas, and in fact, over the summer, we even haven't closed some of those, but we have over this last week in particular had to extend that. And that puts pressure on us around our workforce, but it's important that we try and keep that flow going. So yes, we're under pressure, but the plans that we have in place, I think, will be supporting what we need to do. Our partners are supporting us, which is really important. We are planning for Christmas and New Year, because obviously we've got quite a big holiday season. It's not helped by industrial action now, but as I said, we will work that through, and I'm confident that that will maintain patient safety. We have got part of the initiatives that we always do going into Christmas is that we do a very concentrated week and a bit, I think it is. So it starts the 16th, Jackie's going yes, 16th of December, whereby all our partners and ourselves come together and we work towards getting patients home for Christmas, which is really quite important. And so those things are in place. I think if we can work, Jackie's talked about additional capacity, we've talked about putting additional capacity in. I think if we can work together as we have been doing, then, you know, we've got a good mechanism to do. So I think, no doubt, it's going to be extremely challenging, especially with industrial action on top of it. But I've got confidence in my teams. And as I say, we have to use our methodology of making sure that we are really putting the things in place, the basics, to make sure they're in to keep that flow going.
Thank you, Jane. And I would say to you, if you had a magic wand, you'd probably say you'd have 2 new hospitals or you know, many more buildings. But for that reassurance, are you getting the support with discharge from the ICB, from HACP, etc.? Are you getting the support that you would really want to see to be able to deliver what you would really love to deliver in Medway?
I think, yes, we are getting the support. I would love not to have up to 120 people that shouldn't be there. They are better in the place of care where where they're going to. So I think it's really quite important. But I think, you know, some of the things that, like I've said before, you've talked about tonight, we've got to work together as a health and care partnership, not just about the now, but about the future and the strategy. And that's really quite important. So I think, you know, we need to be working really hard at doing some of that. You know, that preventative bit is really so important about hospital avoidance. You know, if you don't need to come into us, let's not get there. Let's do something different. And we can help with that. Just because we're an acute hospital, we can still help with some of that. And I think that's really important.
James, do you want to come in on that?
To be fair, Chair, Jane actually just touched on it. It was that key thing. We've got 278,000 residents in Medway. Each one of them has got a bed in the main. There's only so much capacity within the hospital, and what we've got to reflect on is the really helpful comments that we had and the discussion around the integrated care strategy and our joint local health wellbeing strategy. And the big ticket item within all of that is to support and to prevent people from escalating to a point where they do need to have, and when they do need to have clinical care, let's get there. But there are opportunities for us to actually to support the hospital. And one key thing this time of year is vaccination. We haven't been impacted at this moment in time significantly by seasonal flu, but who knows when that wave might come. So the more effort that we place on supporting people to do small things, and I know some people may have a challenge with being vaccinated, I understand that, but we do need to promote it as best as we can, and that will help to reduce the impact on the acutes. We're in a huge building at this moment in time that's warm, so encouraging people in some ways to use those warm spaces that we've got around the space, particularly older and more frailer people, will help to reduce the likelihood of them deteriorating in this period. And then the final bit, of course, is connecting people to the services and the support that's available outside of the acute setting. I think a lot of the comments that we've heard today will require different triangulation from different bits, but everyone defaults, don't they, to the hospital, because that's where they know that they will receive care and support. There is so much care and support available in other places. We've just got to help people to understand that it is there for them at a time when they need it. That was all I want to say, Chair.
Thank you, James. Just a couple of last comments from me, Jane. Just to take away the survey results, I'm not sure I saw the last lot of staff survey results, but I can always ask for them to be sent through. But I look forward to seeing your new staff survey. We probably will have a discussion in due course about the comments you made around services and community services joining up, etc. That will be discussed definitely at a later date. And maybe we can hear what that magic wand will be like from you, maybe in next year sometime, about what would be good for, because you're doing a sterling job there. You are really doing a good job. I'm sure the committee would agree. And we did go and see some members went and saw the Healthy Living Centre in Rochester. and we was very impressed what would be going in there. That will be groundbreaking, I think, for your service, and possibly the new site in Chatham as well. That would be really helpful. Finally, I just want to say that, you know, Councillor Llewellyn-Printer made the point about a lot of our email boxes are full up. They are full up with people waiting long waiting times in hospital. You know that yourself. There's an average from something like 12 to 30 to 40 hours, you know, sometimes, depending on what they're going in. You would have expected me to say I've experienced that, but I want to put a different, you know, I waited a long time in there just recently. But what I want to say is that I want you to take back the doctors were amazing, the nurses were amazing, the care I got in the corridor was amazing. So, you know, yes, I was in a corridor, but I want that positive message to be taken back, that you can put people anywhere in that hospital as long as you've got someone looking after them with the right care. Then they are getting help and support that they need, no matter where they are. So please take that back to your staff, and please thank them from all this committee and wish them a good holiday season, or any break they're going to get over this next few months. So please send our thanks back to them for hopefully a happy and healthy new year for all of you at MFT. But thank you, Jane. Thank you for coming. Vice Chair?
Yes, so I move that we note the report.
A seconder, please. Councillor Llewellyn-Printer. Is that agreed, members? Agreed. Thank you. We'll have a quick 5-minute break. Thank you very much, Jane. Thank you. 12. If you can just give us, members have read the papers, but if you want to give us a very short introduction, you can, and then members can ask questions. Thanks, Chair.
Evening, everyone. So, yeah, this paper is about home care and extra care services that are provided across Medway. This paper provides an overview of the way in which home care is delivered to people in their own homes and the care and support that is delivered to people in the 5 extra care schemes in Medway. The paper sort of outlines how we commission those services and I suppose that the contracting model that we use to contract with care providers. Sort of in its current form, and then it touches on the recommissioning process that we're currently going through at the moment to re-procure home care and extra care services across Medway. Something that isn't in the paper, but I will touch on because it's come out in some of the discussions this evening, is the focus we placed in the new specification in the new contract around enablement. So let me catch my breath, apologies. So that is sort of care provided to people in their own home for up to 6 weeks. And the whole idea, I suppose, is to, you know, provide that care up front to enable people to, in the long term, hopefully reduce those long-term care needs. So that helps people remain independent in their own home for as long as possible. Thank you.
Members. Councillor Printer.
Hello, thank you for the report and coming along. I just wanted to ask a question. It's probably really simplistic, but is the electronic call monitoring system what you use to monitor the jobs of the carers, or is it something that happens with the actual end user? I've got other questions. Do you want to do that one first? And also, understand the basket approach of hours that are given to people for the care they need, and that's looking to continue with your new provision. With the carers, the care companies that you appoint, do you monitor them for their treatment of their workforce? With the actual carers on the ground that are running around all around Medway trying to deliver this care, the prescribed amount of hours with quite a skeleton staff, how do you monitor their sort of welfare? I've seen some walking between jobs, I've seen some getting on buses. They're heavily reliant on, because some are from other countries and they may not have a driving licence or be able to afford a car. So what sort of support is out there for the workers? Because how are they going to get to all these jobs for the prescribed hours that the end user sort of prefers? Because we don't want to see people put to bed in the afternoon, you know, like there had been cases in the past. So if someone says they want to be put to bed at 8, 9 o'clock, 10 o'clock at night, how are they managing to support those staff on the ground? Thank you.
So the ECM that we mentioned in the paper, electronic call monitoring, that is where a care worker will effectively log in and log out of a care call. So that then keeps a record, it keeps a track. It logs how long that care call was. Different providers do use different systems, but 9 times out of 10 it gives the functionality to record the care that's been delivered. And most systems also allow for family members to sort of have access to this online system as well. So that sort of keeps a detailed record. As the local authority, we ask for that information, or we can obtain that data. So we've got a clear record, I suppose, of the care that's being provided. You mentioned basket of hours. So yeah, we introduced that 4 years ago. So rather than sort of time and task based, we sort of say an individual might need 10 hours of support a week. And the emphasis is then on the care provider and the service user to kind of discuss how that care is going to be delivered. So the whole idea behind a basket of hours is that it gives the service user sort of greater control over the care that's being provided. On the workforce topic, we have regular meetings with our providers. We have monthly contract management meetings. We have various forums. So we're we're very much in contact with our care providers. Workforce over recent years has been a struggle. I think that was helped by the sort of incentive from the Home Office, sort of overseas workers. That's an improvement in terms of capacity in Medway. But beyond being in regular contact, I suppose we don't necessarily, that's not a direct line of questioning that we have with care providers. So I'll certainly take that point on board to ensure that, you know, whilst we're focused on service users and their outcomes and the care that's being provided, you're quite right, I think, to mention the workforce side of things as well. Because without carers, without the workforce, you know, the care isn't going to be delivered. So thank you for touching on that point.
Jackie, do you want to just touch on?
I think just talking about the areas, you were talking about people moving. In the paper, it talks about this being locality-based. So by it being locality-based, you would only expect carers to work in a certain area. So the care provider, when they're doing that allocation of duties, should be looking at how easy it is to get around. We know that's not the case. I spoke to a carer recently who said to me they were asked to get from one side of Who to the other within the space of about 10 minutes, and that's just not feasible, not possible. So those sorts of things that we do need to pick up. What I wanted to comment on was obviously from a CQC point of view, these providers are registered to provide personal care, so they're registered with the CQC, so that is also something that they would be looking at about the treatment of staff and so on. So although we don't tend to do that, and again, it is something that we can look at, the CQC will be looking at it anyway.
Thank you both. So just on your point, Jackie, locality one, I mean, that covers Gillingham North all the way to Hempstead and Wigmore, and if someone's on foot, that's not practical, is it? And I understand what you're saying, that if that's not going to be a problem. So they only cover the same ward, is that what you're suggesting?
So prior to 4 years ago, I'll just give a bit of a very brief overview. Prior to 4 years ago, a provider could have worked across the whole of Medway. So we split Medway down into those 3 localities. A provider is appointed to a locality. Number of different reasons, I suppose, but benefits in terms of, you know, increasing efficiencies, reduce travel, and actually having a provider, and the feedback from providers is that being in one area enables them to focus on that area and actually use their staff more wisely. So they're not travelling sort of distances across Medway, so they can be as efficient as possible. So yeah, that was a sort of key driver, I suppose, behind going to that locality model.
Yeah, I just meant that those 2 places I mentioned were in the same locality, so potentially someone could be given a job in either one, and if you're on a bus or on foot, that's difficult, but I get your point, I understand, thank you. And just the reporting of times that you say you get report back on the electronic monitoring, how do you, if you've got a carer then who monitors, they've logged in and logged out, they've been there for 15 minutes, they were supposed to be there for half an hour, do you take that into account and adjust what you're paying the provider, or is that just accepted? Because that's an expense to the council, isn't it, that hasn't been paying for a service that hasn't been delivered?
So I might be talking on behalf of Jackie here. So at the moment, providers submit invoices for should be the actual care that they deliver. There is a piece of work ongoing at the moment, and I'm hoping I can say, yeah, there is a piece of work ongoing at the moment. Our social care management system, Mosaic, there's a product, an additional product that you can sort of purchase, I suppose, from the provider that enables that electronic call monitoring data to be used as part of their invoice. So whilst we don't have the functionality now and it's not totally digital now, yes, work is underway that will enable effectively that data, the record of the care that's been delivered, to be used as their invoice. So we will have that ability.
Thank you. And I was by no means saying that anyone is deliberately doing that. I was just wondering if you were able to do that. And I wanted to just say that the carers do a thankless job. Wherever they've come from, here or abroad, we need them. And, you know, you can't really measure how much we need them in terms of money. So thanks very much.
Thank you very much, Councillor Prenter. Councillor Campbell.
Thank you, Chair. Thank you for that report. I guess I just wanted to quickly share a personal experience. I had recently had to access home care services for a family member. And I have to say the speed from the point of assessment to when the carer started visiting was brilliant. It was so good. We weren't actually expecting things to be so quick. And then when the carers did come in to provide the service, there was a little period of adjustment where we had to obviously understand each other. And I was the carer before that, so that happened. And I want to say, in the most part, it was great. The carer was empathetic and kind. But then often we would find he would be replaced by other people. And that's where the problem was. And then there was real variance in the kind of service that we experienced. And they do an amazing job, and I think it's a difficult job, and they work under difficult circumstances. But for us, as the service users, it was a bit distressing at times to see a new person who would come and say, I don't know where anything is, I don't know what I'm supposed to do. And the whole point of it was for me as a carer to have some time out, and that didn't always work. Anyway, the point I'm trying to make is, continuation of the same carer and that kind of streamlined, service, is that one of the metrics you insist on? Is that something that your providers are measured on so that they, maintain the same? Because when people are that vulnerable that they need care, they need to see the same person, and they need to have that continuation. So I just wondered if that's something you hold them to account for.
Yeah, I completely agree that continuity of care is key. And very much within our specifications to care providers, we emphasise that point, that where possible, a smaller number of carers as possible, going into an individual is what we'd expect, what we'd like. Obviously, there are times where carers are off sick or holiday, that can't be facilitated as sometimes as much as individuals would like, but continuity is definitely key. In terms of sort of a metric, a marker, one of the sort of metrics that we do have at our disposal is we ask care providers to survey service users sort of routinely. That survey gives us the ability, I suppose, to ask questions of individuals and survey how that care is. So that's a way in which we could sort of ask specifics around continuity of care. So we do have that ability. And that survey will be developed with providers in time for the contract going live at April 24. So I would say we have the ability, yes, to have that as a metric, as a marker.
Thanks, Councillor Campbell. Councillor Ahmadishi.
Thank you very much for that report. I just want to update the group. I had a conversation with Ian Truman, the CEO of the CQC, at an event last week, or 2 weeks back, and he described the plight of care home staff as the poor looking after the poorly. And so these people who are doing tremendous work, they're probably the least paid, least remunerated people. So it touches both my colleagues' points about continuity of care and what provisions are we putting in place to help the people delivering the care. So I was just thinking more about, have you thought about supporting them on some sort of educational credit so that they can get more trained, so they can either go into nursing, dentistry, anything health related? I know some of them are doing MVQs, but is there any way we can incentivize some of these schemes so that there has to be emphasis on higher education outside of just the education you need to do to deliver care to that individual? So it leaves people just stuck in that, wading through high waters. So one carer said that they can't move. The skills they have, they can only do that one task.
Jackie?
Thank you. I mean, it's nationally recognised that the work that the carers do and the fact that the amount they are paid is low. And I think there's been some challenges when you look at the perhaps healthcare assistants that are in the NHS get paid more, and there's a debate about the role is very similar. And because of that, Kent and Medway system, so the ICB and the councils, I'll have worked together for a period of time. I think probably, I'm looking at Mark, probably about a year or so, where we've been looking at actually what can we do to support people to be able to progress. So, you know, could it be that that role evolves and you may be a carer, then become a healthcare assistant and to be able to move on? It's trickier because obviously carers are funded by the local authority, healthcare assistants are funded by the NHS. So there's those intricacies around bureaucracy, but it is a piece of work that's underway to look at what we can do to support people.
No, thank you. I'll really urge that work to take place to try and incentivize the carers and modify the carers role to make it fit for the 21st century. It's so, so important. When we talk about carers, I was speaking to somebody who is the recipient of care, similar to my colleagues' feedback, and they described each episode as a first date. Every time a new carer presents themselves, they have to go through the same rigor, explaining who they are, what their preferences are. How can we stop this first date syndrome? So I think we talk about integrated care, joining up services, systems. Education is something I think we can, might be low-hanging fruit that we can try and join it up and say, okay, fine, if you're a carer, we want to make sure, before we give a contract, let's see how you're going to provide additional education. So they can pass on that knowledge, because when a carer leaves, 9 out of 10 times, from my experience, they don't really hand over to anybody. They just have enough, I can't do this anymore, and they go.
Thanks, Councillor Hamdishi. I think, Jackie, I think that you know, it's a really good point made. I suppose it can be picked up in commissioning, right? You could be looking at providers and seeing what the, you know, there could be a minimum. I know we do, but there could be a minimum framework of expectations we want providers to provide, and along that education stuff and everything else could be within that. I think it'd be a really good. I know there is some of that stuff going on, but it could be a really good. Did you want to just comment on that?
I mean, providers, the care providers actually have a regime of training that they are required to provide, and that's not necessarily from a commissioning point of view. Actually, that's from a CQC perspective. So we monitor the training. I mean, we keep talking about pieces of work being undertaken, and it feels about everything, but it is true. Actually, a piece of work has been undertaken by a quality assurance team recently to look at all the training that's provided for a cohort of care agencies to look at where the gaps are, and then we can support them with what additional training needs to take place. I do think one thing we have to be really cautious about, though, is that we can encourage and we can support, but we talked earlier on about the budget challenges. So we do have to consider about how we do this as a system, how we work with our partners in education, universities and so on and so forth, but we haven't got a budget that enables us to do that. So that we have to be creative about it.
Sure, and very last point. We know there's an acute shortage of nurses. It's well documented. So there's a resource out there in terms of people delivering frontline care, but it's very specific to the industry and it might not be recognised by a nursing and midwifery council. So joining up, doing the gap analysis, as you rightfully said, to say, look, this is what we do, how does it correlate to what a nurse does, and then bridging that gap, for me, that makes more sense. Thank you.
Thank you, Councillor. Yeah, when I was saying about the Commissioner, I meant about making sure we do the checks on that training, etc. Can I just say, thank you so much for your for the work, Jack. I think, you know, just looking at the first line, when you look at 495,000 hours of care and support, that's amazing. You know, that is amazing. We've got to look at that across the piece, and it's a, you know, that is a massive task to deliver. Whether it's some bits are good and hopefully lots of it are good, and whether there's some gaps that need improving, that is a really good outcome. The only small worry I had about this new contract, and is, I suppose it's about resourcing, is about when we talk about the basket of hours approach, we get many residents say to us that their partners, their parents, etc., have no choice. They're being put to bed at 5 o'clock. That's all they get. That's the choice they get sometimes. They say 5 o'clock, or it might be 11 or too late. There's no, you know, and we know a lot of people don't normally go to bed at that time, and, you know, they don't want to also eat and then go straight to bed either. So is there any work being done on that with regards to this contract around, because you said you're giving the service user more choice. What does that actually mean on this contract?
Okay, so service user, will, I'm sure, have conversations with the social worker about the care they would like to receive. Some of that conversation will be around sort of the times of the care calls that are delivered. So, very much it should be service user choice. It's disappointing to hear, if that time of call is being led by the provider, that definitely shouldn't be the case. It should very much be the service user in the driving seat when it comes to times. Yeah, I suppose that was what I was going to say, Jackie.
Sorry, Jack. I think one of the things, so we know about the pressures that we've got in care homes. I mentioned earlier on about the lack of bed availability. And there's always been a bit of a view that if you receive a certain level of care, actually you then fall into the realms of, do you need 24-hour care in a care home? What we need to look at, and I can't say that this piece of work is underway because it isn't, but what we need to look at actually is how we deliver differently. So at the moment we'll say you may receive, you can receive 4 calls a day, but what we might need to think about actually is, do you need to receive 5 calls a day? And your 5th call of a day might be in the evening, so that you don't have to go to bed at 5. Because actually, you're absolutely right. That should not be the case for anybody. In the same vein that I've had somebody say to me that, they like to be out in the garden, but they are taken out into the garden and sat outside for half an hour a day. That's not a life. So it is something I think that we can look at and see if that's something that we can change.
Thanks, Jackie. Councillor Blake, just a quick one from you, because it went to me, I didn't see your hand, sorry. So
No,
just
it's
going back
okay.
to you for a question.
No, it's okay. No, thank you. It's comments rather than questions that I have, actually, because certainly my involvement with this particular sector over the years goes back a long time. And in that time, I've come across a variety of scenarios. And you mentioned service users. The number of times that I've come into contact with people who, when a carer who's been assigned to be looking after a particular person, perhaps has got a hospital appointment, or in fact, or perhaps they're due some time off. We then have to deal with complaints from the service user who can't understand why somebody else has had to come along and be their carer for the day, simply because, well, who is this carer who's gone off and had a hospital appointment or having a weekend off? They can't quite understand, and they seem to believe, sadly, that people are there 24 hours a day, 7 days a week, and they forget that we all need a little bit of time off from time to time. And these are the sort of things that have to be gone through with some of the care users or service users. But the other thing that I do remember, and that was an event that was held down at the Pentagon, where a lot of care homes and a lot of providers actually came together asking people, would you like to come and join our team as a carer? But there was only one company there that I believe was doing the right approach. Instead of saying to potential carers, this is where we are, we want people to be available from 7 o'clock in the evening right the way through until 9 o'clock at night, they were actually asking people, what time do you have available? What are your working hours? What would you like to do? And working around the availability of people. And I spoke with this company after the event, and they were probably far more successful than all of the others who said had a rigid timetable. So I think this is something that also ought to be perhaps given some consideration. Thank you.
So thank you, Councillor. I think it sort of endorses what Councillor Hamadeshi was saying about that change in working, which is a good thing. Vice Chair.
Thank you. I move that we note the Cabinet will be recommended to award the support to live at home services contracts to the successful bidders that will be evaluated as the most economically advantageous against the Council's award criteria. B, note the support to live at home service will replace the current framework agreements for the provision of home care and extra care. And C, note that a Gateway 3 report will be submitted to the Procurement Board on the 20th of December 2023 and Cabinet on the 16th of January 2024.
Thank you, Vice Chair. Seconded. Thank you. Is that agreed, members? Thank you very much. Thank you, Jack. Thank you very much. Have a good night. The work programme, Michael, please.
Okay, thanks, Chair. Just one thing to update members with on the work programme. There was a suggestion that an update on pharmacies and dentistry services comes to the January meeting. Following discussions with colleagues from the ICB, there are some sort of practical timing difficulties with that, so suggesting that that gets moved to the March meeting instead.
Okay, is that okay with members? There was a debate, so it went backwards and forwards. We definitely do want CCAM here, but it will be March. So, as the Vice Chair.
I move that we agree the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in the italic text.
Is that seconded? Seconded? Okay, agreed. Thank you very much. Thank you, members. Okay, moving on to item, nearly there now. Item 14. It's the Kent and Medway Integrated Care Board Community Services Procurement Update. Okay, hi Mark, hi Ivor. Before I move forward, can I just remind members that there is an exempt appendix to this report which contains commercially sensitive information held by the Integrated Care Board. We will discuss the public report first on camera, and we won't do an exclusion. So please do not discuss the exempt appendix until you may want to nearer the end of our discussion, and then I will ask for an exemption. So at least we keep it on camera and keep it public. But if you do need to address the exempt appendix, then please do that at the end, and then we will close the session. Thank you. Thank you, Mark and Ivor. Please take the report as read. You may want to just introduce yourself for some members that don't know you both, though, please.
I'll go first. Thank you, everyone. Mark Atkinson, I'm Director of System-Wide Commissioning and Operational Planning for NHS Kent and Medway ICB.
And I'm Ivor Duffy, I'm the Chief Finance Officer of NHS Kent and Medway ICB.
Thank you, Mark and Ivor. Just a quick message as well. The reason, sorry, you're here to the end of the agenda. Obviously, you had an exempt appendix. I know that was explained to you. I know there was some debate as well, but I just want it'd be a really good thing to take back to your office for them to realise that I know that you as officers work and have long days. So do members on this group, and many members work as well. So we have early starts and late finishes. Mark, is it you that's given us a very brief overview just to go forward?
Please, if you don't mind. So I recognise that people have read the report, but it's probably helpful if I can just go through some of the key points and also some of the changes that have happened over the last couple of weeks, slight changes, tweaks. So I attended HASC back in September the 20th, and we presented the Community Services Procurement Paper strategy. Following a helpful discussion and I suppose some critical, a helpful critique of our paper and our strategy, and we went back to the ICB and reviewed a number of options. The ICB has also sought some specialist commissioning support from a company called Arden & Jen, who provide our commissioning support, and also some legal guidance. I think we heard Jane describe some of the challenges around winter and the numbers of beds and criteria to reside that they're struggling with. And likewise, within the ICB, we recognise that this winter is probably going to be one of our most challenging winters. And on top of that, we've obviously got the continuation of the industrial action. There's some other key NHS milestones as well. So we're about to start the operational planning, which will probably start at the end of December, and that's obviously a key milestone for us. And the reason I mention that is because it's labour-intensive, resource-heavy for the ICB, as it is actually for all of the providers. And then also the final interesting fact is that NHSE have released the provider selection regime. That's due to come into place at the beginning of January, and that will help us help support the future commissioning and contracting in the future. So we've also taken the time to go back and engage with the chief executives and a number of the providers. And I've attempted in the paper that you have in front of you to cover off the key 5 concerns which you raised in September. So hopefully I've gone some way to provide you with some assurance. The important things just to bear in mind are that following the comments from HASC, the ICB has a priority to maintain the community services. All of the 3 contracts expire within the 6 months, so we need to do something. Not doing anything is not an option for us. So therefore, we are proposing that we extend the current contracts by up to 2 months with a 6-month break clause. And that's currently a dynamic process. We are working with the providers, engaging with them to get that in place. The advantage of that is it allows a harmonisation of those contracts because we had them starting and finishing at different points, and it would lead us to a final end date of probably September 2025. What that does do is it allows us a little bit more time, and I think that was one of the concerns from HASC previously, and we'll use that time wisely. We would go and we would re-engage with stakeholders, providers and patients. And I think it's really interesting when you listen to, again, some of the opportunities which we should be taking around better community services, I think, to help and support MFT and our other acute trusts, but also some of the constraints we've heard around the care market and the care situation. So we'd like to work with the councils to help and revise, reform our plans on strategy over the next 18 to 24 months. I think there's one just key important point that I will make. So when we came in September, we were really keen to make sure that that transformational piece was included in the contract. We're not able to include that in the contract, but I do think that we'll be able to work with the current providers to deliver, or certainly start to deliver, that transformational work. And they are key to helping us to deliver that transformation, improving the outcomes for our patients, improving the care, but also delivering some of those efficiencies which we keep recognising we need to do to make the NHS more sustainable, and again, working with all of the stakeholders and providers. So I think that's probably all I wanted to say, but I'm obviously happy to do my best to answer your questions.
Members? Okay. I have some questions for you, Mark. I'm sure you would think I have. I mean, I think I have to start by saying, first of all, that I remember at the meeting you came to, and I remember Lee Martin told us very clearly that it was either this way or no way. I remember that. You sat here, you not in here, it was in the other room. This is slightly different. You sat in that room and you said to us very clearly, it was put to this committee very clearly that there's no other way by this way, because we've got 6 months to go, we've got to clear this. Any suggestion we were making about extending was dismissed. And that was very clear. And then by magic, you've now, well, I'm going to say it, Mark, you can come back at me anyway, I will give you the chance. I'm quite happy to have a one-on-one here. By magic, you've now come back, and I do thank you for coming back with the extra bit about the one-year contract. Because that is all that's really in this document that I can see. I can't see myself the meat within this at all. Okay, so what you've come back with is, first of all, you've come back with actually agreeing with this committee by saying that after you've sought consultants, and I'd hate to think how much that will cost, your legal and your commissioning consultants, which could have, been spent on services. You've now come back and said, you know what, we can do it. We can take a longer time to do this. We can take up to 2 years, possibly 1 year with a year extension. We can do this now. But we're not going to involve the partners in the transformation, though. Because that was your key selling point before, is that they would be involved in it, they would be really immersed in it, they would help you shape this. And I'm going to say shape this model that I don't really know what that model is. And I know you've had the same comments from HOSC as well. So, you know, for me, first of all, when I see that 1 year extension, I think, okay, we're moving in our direction now. A sensible approach to involve the different services in Medway to make it better. Because that's the aim, isn't it, of all of this? You know, we all agree, we're on the same page here, we need to do something different. There needs to be something different in Medway, it needs to be delivered effectively. We need all the services to come together. Jane said that just a minute ago as well. And I think you heard her make that comment about something has to change. So we are on the same page with that. Members can shout me down if not, but we are on the same page with wanting what's best for Medway. Of course we worry about Kent, but we're talking about Medway here today. So when I open the paper, there's nothing, is there? There is nothing to tempt me in. You've answered the questions, Mark. I'm going to praise you for that. You answered our questions, right? But there's nothing to tempt me in to tell me what is this transformation. You know, you're probably going to do scoping exercises in the next few months with individuals, hopefully, whether it's directors involved from Medway, etc. But where's the meat of this? Where is the meat of this wonderful transformation programme? And again, it's a missed opportunity, right? You've missed an opportunity today. And, you know, and I am going to talk about HOSC because you wouldn't not expect me to watch the HOSC committee because I did. And, you know, members there, as well as I'm going to say, this, whether you like it or not, whatever's going to happen in the next year or 2 years or 2 years and 6 months is a substantial transformation of services. We can all sit here and pretend it's not an SV, but it is. It is going to be a substantial transformation of services. But you know what? It could have been different today. The assurances could have been different. It could have been very different tonight if there was assurance. And we haven't got that assurance in front of us. And do you know what? To the point of saying, you've seen that members are always very passionate on this committee. You know that, Mark, they are, and either you'd see that if you come here more. But for the point of saying, you can see members are not even engaging in this because the disappointment is clear. You know, again and again and again, I say, sit round the table, talk to us, speak to the, respect the HASC committee and what it represents. And we haven't got it here in front of us. We haven't got it, Mark. And, you know, I will give you a chance to come back briefly and then I'll finish what I'm going to say. But that was where I think the disappointment, we were really expecting something. You know, you've gone away for a few months now, something really good to show us what this is going to look like. And so you can understand, you probably all know what it's going to look like, but we don't. You know, you've probably got a vision somewhere, what you want this to look like and what you want this new, because this mess, what it's going to look like in the end. But it's all in your minds, but not visible to us that have our residents' health and social care responsibilities at our hands here at Scrutiny. So I'm disappointed, Mark. I mean, you can come back, but I mean, and I'll tell you where I go from there.
Okay, thank you very much. So there's a couple of clarifications that I think we need to make. First of all, it's a 1+1 contract. And as I mentioned earlier on, we run the risk of not having any contracts in place. So the ICB needs to do something. We did say that there was, you know, a risk that if we didn't do something, we'd be in a really difficult position. We sought the legal advice and the specialist commissioning advice because this is a really complicated decision that we've taken. And we're open to potential challenge. So whatever we've done really, really carefully, recognising that we need to do something. So this paper was, I thought, answering the questions, the 5 key areas of concern. It gives us some time to go away and come do the engagement, to do the pieces that you said you wanted us to do. I think I wasn't expecting to come today and deliver a new strategy, and I want to work with all of the councillors from both HASC and HOSC, and I want to make sure, I live in Kent. My wife has used the services at Medway Hospital, so I want to make sure that we deliver the best services. So, you know, you can be assured that I'm here to make sure that we make the right changes, but we need to do this in a careful way, because, as I've said, we would be open to potential challenge.
So thank you, Mark.
And sorry, just one last thing. So we do need to work with the providers. We need to work with the likes of Jane and Martin to make sure that we get the services right. And so when we came in September, we did say that we wanted them to do that transformational work. They needed to deliver that transformational work. These are the providers. These are the people that are delivering services. These are the people which know what's wrong and what's right. They don't need a Mark Atkinson telling them how to do things. They need to be able to tell me, Mark, you need to put this right. Make it better for us. Make it easier for us to work. And actually make it, I think one of the criticisms we had was that we need to do something to make Kent and Medway a vibrant place to come and work. And I think some of that transformational work would deliver the interest. If you go and read the HSJ, there's a really interesting article around Bath ICB, because they've been doing that same piece of work. And interestingly, if we contacted Bath after HASC, actually, because we reached out and we said, we've been having some of these challenges. It'd be really interesting to sit and listen to what you've done. So I've reflected on what their suggestions were, and I think we do need to go back and do some of that engagement. And I would be keen to work with HASC and HOSC.
Thank you, Mark. Can I just make it really clear? I've got no doubt about your passion for the health service in Kent and Medway, honestly, no doubt whatsoever. But there's history here, remember. So when and for new members as well, when we sit at this committee and we say we want the best for Medway, remember already Medway had lost its stroke services, lost its mental health units, lost a lot of things through the years. I'm not revisiting that, but we have. So you can understand why we're very nervous and why we want the best for Medway, when slowly but surely we saw loads of services being taken out of Medway. And actually, there is still some bits of that still happening now, which we're challenging and scrutinising. I'm not saying you're bringing a new strategy here tonight, because I think we don't know what the strategy is. Because the strategy that's coming on a piece of paper is there's a transformation programme. What is that transformation? Members have been really good this evening with their comments. I think colleagues will agree that they've done some really good questioning. Some of the questioning has always been about what's behind it, what's under it, what's sitting under the document. What value does it have for Medway and for Kent? But Medway we're going to talk about. And I'm going to have to say it again. It wasn't it wasn't us that told you to come to the last committee, and we were told you only had a few months, you had to do it, it had to be done by, that it wasn't our fault that commission wasn't thought about a long time ago and wasn't instigated by maybe the CCG or whoever in the past. Someone over your side left it too late, because now we're having to rush it through because someone somewhere didn't hit it through when they shouldn't have done. And I'm really delighted to hear you say that actually after you visited HASC, because remember we were the ones that made that SV decision, that you then did go off and consult and change. But from our side, the only change is that 1 year extension. I still can't see the value. But Mark, what I'm going to do is, because you've had a long night here, you've been sitting here for a while, I think you would automatically get the sense that this committee would be doing an SV tonight, because actually I'm telling you it is a substantial variation. It is, okay? But I'm not going to do that. What I'm going to do tonight is I'm going to not make the decision tonight. What's the word I'm using? Yeah, I'm going to defer until January. And do you know what I'm going to do in January, Mark? I'm going to request 4 people back at this committee. The people I'm requesting, entirely up to you, I want a member from the ICB. I'm going to be requesting Jane from the hospital. I'm going to be requesting Teresa, Councillor Teresa Murray as well. And I'm also possibly going to be requesting one at the provider. Because this committee deserves better. We deserve to know what is in your mind with regards to this transformation programme. And that may be the way that we can get there. Because our door is open. You know that, Mark. I've tried, haven't I? I've tried to meet members just recently, not you, but with others. I've tried to meet, but the door is open with this committee, I'm saying. Wide open with the committee. And that's why I'm deferring and not making that SV decision this evening, because I'm almost certain that I could go to an SV. And I'm almost certain, not being just second-guessing my colleagues from both sides, that I would get agreement. But I think we deserve better than that. So I'm going to do the duty of what HAS does, and we are going to require the 3 or 4 people come to the next committee. And we'll triangulate between all of you what's going on. And then maybe, at the end of that, we'll be in a really positive frame of mind. Because, like I said at the very beginning, something has to change. We do have to change something. We do. You know, I'm agreeing with you. But what is it we're changing? I need to know. You know, we don't know that. And you're getting frustrated with me because you know it and I don't, because you know it in your mind and I don't. And Ivor's looking at me thinking, oh, I wish I never come to this house now. But I'm trying to be helpful to the process. So I'm putting to members that we are deferring the decision for an SV, and that I am going to be requesting, and that for new members, that means I am going to be putting an obligation of HASC on those members to all attend the January meeting. And then we get to the bottom of that. And in between that, though, Mark, we can meet up and we can have some discussions of what that's going to look like. Leanne?
Could I make one quick point? So I think one of the things that is missing as well is that we did, we talked about the community prospectus, and I think you talk about you don't know what the vision is, and we haven't shared the vision, and I recognise that. But again, it goes back to the place that we're in at the moment. So we've had negotiations with those 3 providers, and we are about to share that prospectus. We've actually had to change the name of it to the Community Services Ambition, but it might be helpful if I share that early next week, because I think that describes some of the vision that you're looking for, what we're hoping to achieve across a number of those service specifications which we've previously described and appear in the financial appendix. So I think that at least gives you an idea of what we want to do. But again, because we're still in this sort of live procurement process, it's really difficult to share some of that information. But on reflection, it would have been helpful for us to have the conversation in that meeting, which unfortunately got cancelled because we got drawn into a conversation with NHS England, which was you must attend this meeting. I did offer to meet with you, and because I wanted to have the conversation to make sure that we continue to be on the same track and we're not at loggerheads.
Councillor Brake.
Thank you, Chairman. Thank you very much for what you've said, Donna. Dan, it's been absolutely spot on. Every word that you've said is absolutely right. And I think it's right that the decision to defer until January is the right decision. However, it's been suggested that Mark may be in a position to come back to you with some additional information next week. That's fine, but I don't think that goes against the proposal that you put on the table, that this come back and is deferred until January. And from this side of the table, I will be supporting and seconding your proposal. Thank you.
Mark, with the community, the perspective, it would have been, I don't know if you've just written that and it's just been released, but, that if you remember rightly, I must have said it about 10 times at our September meeting. I said, look, just give us the detail. Give us the detail to read, and then we wouldn't be sitting here like wondering why is that detail not being shared. You know, I just, you know, those little lost opportunities, and it wasn't necessarily the meeting with you I was having, it was with Lee Martin and with the Chief Medical Officer. But maybe I talk to you going forward. But this committee deserves a bit better, and we'll be doing that request for the January. So we'll be deferring members the decision tonight. I've had Councillor Bray also second that decision. Are we all, Chair, would you like, Vice Chair, would you like to?
Thank you, Dan. I move that we note the update from the ICB as set out in Appendix 1 to this report, and I note that we will see them again in deferred decision till January. Thanks.
And request the attendance of, not just you, but request the attendance of the other members. Is that seconded? We have already got that. Yep. Okay. Well, is that agreed? Agreed. Thank you, Mark. Thank you, Ivor. Thank you.
No, I wondered if you wanted to do a...
About the exemptor
yes.
One. Okay. Did any members... we would have to exclude the press. Can I just check first? Has any members got any questions around the financial part? No? The exempt appendix? No. Either, so we're okay. So we don't, that's lovely. Thank you very much. Thank you. Okay, members, so we are at the end of the meeting. All members, sorry, members. We are at the end of the meeting. Can I just say thank you so much for all of your responses over these last few months. You have been amazing. Thank you so much for the ones that have covered for me as well and covered for others. We really appreciate that. But, you know, the responses from both sides, we all know we're here for one reason, and that's for our residents. So hope you have, for those of you that don't see, hope you have a nice break. Enjoy your orange and your chocolate. Okay. Thank you. Thank you, everyone. Thank you.